This conference will now be recorded.
My apology for delayed start. It was just GoToMeeting was quite temperamental this morning, so I had to restart it a few times. Right, okay, so we're going to do delivery management today. Who is the first one to start today?
Sujata.
Sujata. Okay, this is for you, Sujata.
Okay.
My camera is open, it's okay.
I can't see the slide.
Give me 1 second. I will just
Yeah. Sure.
What's wrong with it? What's wrong with it? Is main screen of station visible to you guys? That it is also showing you the screen of this GoToMeeting thing. No, you can't see the main station screen.
No, we cannot see Dr. Sophia.
Okay. Give 1 second. Okay, so I guess you should be able to see now. Yeah.
Yes, Dr. Sophia.
Thank you.
Dr. Sophia, I'm
Yeah.
Sujana. I got a booking for this November. Can you please include my name also for doing cases?
I will speak to you at the end of this, Rujna. I know you have
Okay.
booked for that circle session as well, but this group session is, it's the batch which is going on. But I will speak to
Okay.
you after this to let you know what we're doing with your presentations.
Okay. Okay. Thank you.
This conference will now be recorded.
Shall I
Right, okay,
start?
you can start now, yeah.
Yeah. Hello, I am Sujata, one of the doctors in the labor room today. Am I speaking to Rebecca Wood?
Yes, doctor, I'm Rebecca Wood.
Yeah. Can I confirm your age, please?
Oh, yeah, doctor, I'm 33 years old.
Yeah, Rebecca, I see you are in labor, and the midwife had some concern about your baby, so about your delivery. So that's why I'm here, Rebecca.
All right, okay, doctor. Just give me 1 minute, doctor.
Yeah. The pain gone, Rebecca?
Yeah, yes, doctor, yeah.
Are you all right to talk?
Yeah, please, yeah.
Yeah. So I see you're doing well and your womb is fully dilated and you've been pushing for the last 2 hours. How are you feeling, Rebecca?
Well, I don't know, doctor. I have been, pushing so hard for I don't know how long. I just really want this baby to be out now, please.
Yeah, that's why I'm here to discuss with you. And how did you get into labor, Rebecca? Was it
Oh,
did pains?
it's another contraction, doctor. Wait a minute.
Yeah,
Yeah. Yes,
yeah.
doctor.
Yeah, you're okay to talk? Okay.
Yeah.
So you got into labor pains by yourself, and was the pain relief given by an injection on the
Yes,
back?
yes, doctor. Yes, I have this epidural.
Yeah, yeah. And I see that you have been pushing for 2 hours.
Yeah.
And have you named your baby Rebecca?
I don't know, doctor. Just please get this baby out.
Sure, Rebecca. Yeah, and yeah. So the midwife has seen you, and the baby's trace is good, but you have been pushing for the last 2 hours, Rebecca. So it is time for the baby to be delivered, and you're not able to do it. So we
I'm
might
trying
need to.
my hard, doctor. I'm just trying the way she has told me. I don't know. I'm doing what I can do.
Yeah, I know you've been trying and you're doing good, but as the midwife has examined you, the baby's position is in a position which delivery is little difficult because it should be facing to the front, but the baby's head is facing to the back, and that's why you have not delivered. Are you with me?
Yes, okay, yeah, whatever, doctor. Just please get
Yeah,
this baby out.
yeah. So we have two options, Rebecca. See, we can either rotate the baby's head to the front, and then with either an instrument, either a vacuum or a forceps, or we can go ahead with a cesarean section because you have tried for 2 hours and baby has not delivered. What do you think, Rebecca?
I mean, I would really like to deliver normally, doctor. I've just been through so much now, and now I don't want to get up on the cesarean. So
Yeah,
please try whatever you're saying, rotating the baby around or whatever.
yeah. So we can use a suction cup if you are okay with it, and with that we can rotate the head so that it comes to the front, and then it can be delivered if you are okay with it. Otherwise,
Okay.
we can. Is that all right with you?
Yes, yes, doctor. Yeah.
Okay. So can we go ahead with that if you're all right? Before that, can I ask a few questions while I'm getting the things ready for the
Okay.
delivery?
Yeah, yeah. Okay.
Yeah.
Yeah.
Are you allergic to anything, Rebecca?
No, doctor. No, it's from aware of.
And you don't have any other problems during your pregnancy, any raised BP or
No,
diabetes?
no, no, doctor. No.
And your first delivery was a normal delivery?
Yeah, that was yeah, straightforward. Yeah.
Yeah. So that is fine. And you are aware of your height for weight ratio also?
Yeah, doctor. That was 25.
Yeah. Yeah, thank you for that. And with your consent, we can proceed with the cup. So when we put the cup, you will empty your bladder, and once the pressure is built up with the cup, with traction, the baby can be delivered. Only thing is, with this cup, you can have the baby can have little swelling on the head, which will disappear after 24 to 48 hours. And is
Swelling
that
of
right?
what swelling, bit, doctor? Like what type of swelling?
Uh, a swelling of the scalp of the baby.
Okay.
Hmm.
Mm-hmm.
Sometimes there can be some bleeding also into that swelling. We call it Causal Hematoma. That is also not a worrisome uh, thing because it also will go off by itself. Very rarely we might not be able to do the uh, complete the delivery with the vacuum. So we have to try it in the operation theater, Rebecca.
Okay.
Yeah.
Okay, doctor. Yeah.
We have informed the operation theater and we are getting your consent. And if everything goes well, we can deliver you vaginally. But in case there is a problem after we apply the cup, we might have to do an emergency cesarean also. Are you okay with it after
Yes,
trying?
doctor. Yeah.
Okay, so can
Yeah.
you sign in the consent form if you can go through it, and we will shift you to the theater and do the delivery process. Is that right?
Yes, doctor. Yeah.
Any other concern for you?
No, I don't. I don't, doctor. I just want this baby to be delivered. So please do it.
Yeah.
Do whatever you
And
want to do. Do it quick,
yeah,
please.
I informed the baby doctor also. He'll be there so that as soon as the baby is born, baby will be taken care of, and we'll be taking blood for checking that the baby's oxygen supply is all right. And we might need to give you a cut also below so that it will facilitate the delivery of the baby. You're okay with that, no?
Yeah.
Okay. Thank you for your time. Is there any other concern? We'll be shifting you to the
Yeah.
theater.
No, that's fine, doctor. Sure, thank you. Right.
Thank you.
Okay. So, thank you, Sujata, for trying this station. So yeah, so second stage had still just on +1, fully dilated 3 hours. Obviously, she needs to be delivered now. Her head in occipital posterior. So she is, obviously not tired. She's exhausted. She has been pushing hard for so long. This is not the appropriate time to ask about, kind of weight. These type of things like, did you go labor in yourself or what, and what's the baby's name and all that. That's the least. Even she has named the baby and everything. That's the least she can answer. She's you know, she's having contractions, she's trying to talk to you in between her contractions. So I wouldn't bother about this, to be honest. So all you need to do is just go introduce yourself. But yeah, there are a couple of things you need to ask, just keeping in mind your, like, you know, what are the prerequisites of instrumental delivery. So other very important thing, please be very careful. Do not say that you've been pushing hard, but you're not able to, you haven't been able to deliver the baby, right? So I know you mean like the baby hasn't delivered yet, but that the women is very disappointing for the women then, for them feeling like it is their fault. They're not being, it's taken as a failure, that, you know, and you might have noticed she goes in quite defensive mode to say, well, I'm trying my hard, I'm pushing on the way she's telling me. Because it's kind of like you're not pushing properly or whatever, you know. So be careful about that as well. And you know, listen, you how usually we speak in these circumstances. So yes, go inside, introduce yourself, and obviously if she's having contraction, give her time to have the contraction, and just behave normally as we do. You know, if the patient is with you, yes, you know, well, now you're doing really well. Appreciate her a bit, encourage her. And then, you know, you can speak to her, and yes, it's okay to ask about what she has as a analgesia. So if she has epidural, just ask, is it working effectively for you? And then, you know, you try to speak and say, so midwife has, don't say she has concerned about your baby or the delivery. Again, I will be worried, is something wrong with my baby? You know, it's not concern. The concern is from the point of view that we want her to deliver now, yeah, but there's nothing concerning about baby. So you say, okay, so, you know, I can see your, you know, your neck of womb has opened for last 3 hours, and you've been pushing quite effectively for last 2 hours as well. But the baby's head has not quite come down to be delivered. We can't, you know, we don't encourage to wait more longer, because it's been already 3 hours, because it's not safe for you. It won't be safe for the baby. It's not safe for you in a point of view that you will obviously become quite exhausted. And if the womb is contracting so long and you're pushing so hard as well, then the womb can get exhausted, you know, and it may not then contract very forcefully after the delivery of the baby. And that can lead to quite heavy and life-threatening bleeding. So now we need to, you know, give you, you know, give some assistance to deliver the baby. So this is always say, we need to give you some assistance. So how you feel about it, yeah? So involve her to say how you feel about it. And then you can explain her first to say, okay, so what happens is basically, so if you want to say the head is in the back position, should be, she said back of the head, yeah? So what should be on the front, yeah? Face, what should be on the front? So the back of the head. So you say, so usually what happens, and again, you can make that, you know, hollow with your hands, both hands in front of the camera, and then you can say, so usually, you know, for the right position for the baby's head to deliver is at the baby's back of the head, and you can touch your back of the head to say the back of the head should be in the front of your bone to deliver, to be in the right position. However, your baby's, you know, the back of head is slit a bit, you know, still towards the back of your bone, and in that position, basically, you know, baby can't deliver. So what we need to do, we can either, I wouldn't say to her like options, to be honest. I will explain her what we're going to do, what we can't possibly do. Okay, say options. So what we can do, we can try with the some, you know, vacuum, we say suction cup, like applying one plastic suction cup in the back of the head of the baby, and then try to, you know, and just your hand, just help her to understand. We try to bring, you know, rotate this back of the head forward, bring it down in the position, and then baby can deliver. However, there are, you know, some risk with this procedure as well, and there is a risk that it may not be successful. Like we try, you know, a few times, but we're not able to bring the baby's head in the right position. Or, you know, the cup gets slipped frequently, then we can, you know, try our forceps, depending upon if we have the expertise, depending which position the baby's head is at that stage. But it will be more likely for us to then proceed to cesarean section. So how you feel about this? Again, yeah, involve her. Again, in between, if she has a contraction, give her time. And then you will say, if she says yes, you do whatever you want to do. And you can say as well, like, so then you can say, or, you know, you can, it's really up to you. The other option can be, if you don't want to, you know, take the risk to try and if fail, go to cesarean section. We can proceed direct to cesarean section as well. However, you know, it's, you know, in this because it's quite down as well, the head now, it usually is quite successful. And if you say, yes, I can apply, then you can say, okay, so what I'm going to do now, then I will just examine your tummy again, just to make sure, yes, the head is, quite down, because sometimes actually, because of the pushing, there can be some swelling on the top of the head, which feels like, if the head itself is quite down. So we need to just, check that one and then give you internal examination again to feel the position of the baby's head. To make sure it has come further down, or the position is, will that be all right with you again? Because we see vaginal examination, repeated vaginal examinations are obviously quite uncomfortable, tender for the women as well, so you need to ask. And then CGG trace is ratio, so you can reassure for the baby point of view to say the baby is doing very well, the baby's heartbeat is fantastic, so there is no worry from that point of view. Okay, then you can ask a few questions. It says, I'm just quickly gonna, but say quickly, I'm just quickly going to ask you a few questions just to make sure that, we are okay and there's nothing which should stop us from trying this, to deliver the baby with the help of the instruments. And then you can ask, has there been any concerns about the growth of the baby, your baby's well-being, during your pregnancy at all? Did you have any complications like high blood pressure, diabetes, or any other problems during your pregnancy? And then you just need to quickly ask about the first pregnancy. The second, you have to see you have one child already, so was that normal vaginal birth? Was there any problems? So these are the important, because what we're trying to do by asking these questions is not, again, only for the history purposes. We are trying to ask her about her is there any contraindication that we shouldn't try these numbers. BMI, well, yeah, you can ask, because otherwise the patient is sitting in the exam. The role players usually, if they want to show you high BMI, there will be a bit chubby role player sitting over there, so you will know. The BMI, to be honest, is not very important at this stage, unless she's abnormally quite big woman sitting in front of you. Otherwise, I wouldn't be bothered. Who remember BMI, to be honest, in second stage, fully dilated for 3 hours? So, right. So then you will say, then we need to explain by saying, because we need to rotate the baby, we can't try this inside the room, because it's like there is a risk that we may not be successful actually to move the baby around. And then we may need to proceed, to the cesarean section immediately. And sometime we're doing this procedure, it can, put some stress on the baby as well, and the baby heartbeat may go slow or fast. So these are the few things that which may necessitate it for us to proceed to the cesarean section quickly. There are some risks of the procedure when we apply that, because we apply that the top of the baby's head, and then we have to create a suction to pull the baby down and rotate around. That can result in some swelling on the top of the baby, which can be sometimes just the swelling of the skin. Sometimes there can be a small little bleeding underneath as well, which can affect, like a small blood collection. But that will heal. We will observe the baby. Baby will be seen by the baby doctors anyway, as soon as the baby will be delivered. And then, if anything like that happen, we will just observe it very closely. But if we feel that it's difficult and the baby is not really, easily rotating, then we won't just keep, trying to cause harm to the baby. We will just, stop and proceed to the cesarean section. We will keep you well informed during all that time. So, and then just ask, is that all right? And then say, okay, so what I need to do then, I will need to take the written consent from you. So I'm going to write down all this, that we are going to try your baby to, baby's head to turn around and then deliver you with the help of instruments like with this cup I have spoken to you, vacuum. And if that didn't proceed to the delivery, then we will proceed to cesarean section. Yeah, so you're going to take the consent, instrumental delivery plus minus cesarean section. So you need to take the consent now. And then you need to say, okay, so if in case we are not successful to deliver baby with the help of that cup, then we will proceed to the cesarean. Now, the cesarean in this situation can be a bit high risk, because the baby's head has come quite down and is kind of, quite fixed into the bones of your pelvis. So the cesarean can be challenging at this stage, number one, because we then will need to push the baby's head high up to bring it up actually back into the tummy and then deliver. And that can result sometimes, the extension of the tear, into the opening of the womb, which we will make obviously to deliver the baby. And because the lower part of the wall of the womb has been stretched quite thin as well, there can be itself as a risk as well, that can extend into tear and can cause bleeding. However, we are aware of this, and we do have certain maneuvers and techniques to try to push the baby's head up first from down and then try to deliver you safely. There is a small risk that this womb may not contract very well after the delivery, so we will be giving you some medicine to help it, through your cannula, to help it contract, and then we'll be starting straight away a drip as well to prevent this bleeding from happening and help the uterus to contract very well. Okay, so these are the few things you need to just talk about. Obviously, in case if we proceed to the cesarean section, there can be small risk of injury to your bladder bubble. So you need to keep those points of the cesarean section consent as well in your mind. Yeah, because if it happens and we won't be able to, really consent during all that time. So that consent needs to be in place as well. And then you will say, okay, so I'm going to call the anesthetist to have a look. I mean, he can then assess whether we are okay to proceed with the epidural, or he will put you spinal. So I leave that discussion for him to take place with you, and we just get the theater ready and keep moving. All right. If she says how long it will take, when are you going to do this? As soon as possible. All we need to do is just this, this preparation to get the anesthetist surrounding the theater ready for you. We will continue to monitor the baby heart throughout this time.
Okay.
Right. Yeah, shoulder distortion needs to be discussed as well with the instrumental to say, like, if we, when we were saying like that, then we will deliver the baby, then you can say, so sometime what happens when the baby is delivered, particularly the babies who need assistance, there is slightly higher risk that after the delivery that the shoulders can get stuck as well sometimes, and then we need to do certain maneuvers to deliver. However, again, whenever you tell about any complication, just tell them what we're going to do, or we are aware of this, we are anticipating this one, so we will be prepared basically to act accordingly. Okay, Sama is saying PPH as well. Yes, Sama, we said like after this there will be difficulty, there can be difficulty for the womb to contract, so that can bleed life-threatening, so there's PPH. Right, okay, so this is how you will be doing this.
Sure.
Why we are not saying about forceps?
Why we're not trying the forceps? So this is rotational forceps. So you as ST5 don't have the skills to do the mid-cavity rotational forceps delivery, right? So you can do vacuum, or we will proceed to cesarean section.
But we can't call consultant for rotational forceps and then to go ahead like that, because in one way we understood that the UK policy is to minimize cesarean right now.
That's right, but to be honest, mostly what happens is the rotational keyline deliveries, they are very less. There are only few consultants who try that. So mostly this is the plan, because obviously what is the difference between vacuum and the forceps? Are forceps more, is there any evidence that the forceps rotation is more successful as compared to vacuum?
No.
Yeah, there isn't.
No.
So the vacuum is comparatively more safer option. It's more easier option for the operator. It reduces the maternal trauma as well, because the rotational forceps delivery leave extensive. That one. But obviously, you need to say, I'm going to inform the consultant as well that we are doing this. You need this delivery assistance in delivery now. Okay.
Hello, good afternoon, Dr. Safia.
Yes, good afternoon.
Dr. Safia, we are in UK using fetal pillow to push the head upward.
Fetal pillow.
Hello. From the down to push, as with the hand we are telling assistant to push the head upward in the second stage. So the fetal pillow is common practice there or no?
Fetal pillow as itself is not, I mean, but we do, yes, we do disengage the head. So that obviously is a recommendation by the guideline as well. So that you need to do, yeah. So we said to her, like, we will push the head up from down below.
Okay.
Yes, you will disengage and push the baby head up.
So we will just say we will push the head from the down to up.
Yeah, you can't go into those details by saying this is for this or this. Yeah, just simple words. Remember, she is in a lot of strong contractions and pains at the moment. She's exhausted. You need to just explain things in very simple and basic small sentences, so she can clearly understand what that is.
But if this station suppose will with examiner as a structured discussion, then yes, we have to take, correct?
Yeah, then you need to just exactly regurgitate what the guideline is, basically,
Okay.
in
And
technical
even the
language.
Patwardhan, if a structured discussion,
If
otherwise
it's
no
structured
need.
discussion, yes. If it's a structured discussion, then you absolutely go according to instrumental delivery guideline.
Okay, okay. Thank you, Dr.
All right.
Sophia.
Doctor, should we rule out blood group and Jehovah's Witness in this stage?
Yeah, you can ask, like, if you bleed heavily, we need to give you blood transfusion. We're talking about the cesarean. Then yes, you can ask. Will that be okay with you? Yeah, that should be part of consent. Yeah, that will be. Yeah, that should be asked. Okay. Any? Okay, who is next now?
Reena D.
Okay, Reena,
Yes, ma'am.
are you ready? This is for you.
Okay, ma'am.
Okay, that's your first 2 minutes.
Yes, ma'am. Hello, I'm Dr. Meena, one of the exam candidates for MRCOG Part 3. I've gone through the scenario and I'm ready for this discussion.
Okay.
So I have my team with me and I will go room by room and I will prioritize the cases as I go to each room. And in each room, I will be applying the S-bar in order to prioritize the cases. So in room number 1, I have a patient who is a third gravida who has had previous 2 vaginal deliveries, out of which one was a stillbirth. She has now gone for induction of labor at 38 weeks for growth restriction, fetal growth restriction. So I would also like to get some background information regarding this patient as to whether all her scans have been normal. And apart from this growth issue, whether there have been any other issues in this pregnancy in terms of her blood pressure or raised blood sugar. And I would also like to get some information regarding her previous deliveries and regarding the stillbirth as well as the one in which she had a living issue. So, however, at this point in time, I would think this to be a semi-urgent case, and I would ask the midwife to go and take the appropriate history and get back to me. Now, in room number 2, I have a patient who is a primary gravida, and she has been induced for post dates. However, the first attempt was a failure, and now she has been re-induced, and she is having a cervical dilatation of 3 to 4 centimeters. So I would like to get a background information as to when this pervaginal examination was done, and if it has been 4 hours, then I would like to do a pervaginal examination again, as well as a per-abdominal examination. And at the same time, I would like to get some background information regarding this pregnancy. And I presume that this must have been a low-risk pregnancy, as it has been allowed to pass the due date. So I would also ask one of the midwives to go and see this patient, and I would allocate this as a semi-urgent case at this point in time. And then in room number 3 is empty, so I will go to room number 4. So room number 4, she is a 4th gravida. She has had previous 2 cesarean sections, and I would like to, now she has come for an elective cesarean section. So I would ask my midwife, one of the senior midwives, to go and see this patient and see if a consent is up to date, and also would like some background information regarding her previous 2 cesarean sections, as to what was the type of incisions given, and how was the recovery after the cesarean sections, and how the offsprings, babies are doing now. And I would also like to check whether she has any other risk factors in the current pregnancy. And I would also like to ensure that the blood bank has prior intimation, and also the anesthetist can come and have a word with her, and the pediatrician is also updated regarding the elective cesarean section tomorrow. And of course, I would involve my consultant in all the details. Then I would go, so this would be, at this moment, this would be semi-urgent. And then I would go to room number 5. Room number 5, this patient is a 2nd gravida, and she is 39 weeks, 3 days into her pregnancy, and she's gone into spontaneous labor. So I would like to find out whether when this pervaginal examination was done, and if 4 hours have gone by, I would like to get some updates regarding her pervaginal examination. And at the same time, I would like some background information regarding this pregnancy as well, as to how this pregnancy has been so far, and whether there have been any concerns in this pregnancy. So this patient can be seen by my one of the midwives, and then I would go to room number 7. In room number 7, I have a patient who is a grand multiparent. She is a 6th gravida, and she has gone into spontaneous labor. However, there is meconium staining, and the pervaginal examination reveals that she is 6 centimeters dilated. So this would be my urgent case, and I would like to go and see this patient myself, and I would like to do reassess the patient to see that whether delivery is imminent, and if so, then I would like to expedite the delivery, as she has got meconium staining. And if instrumental delivery is possible in the labor room, I would go ahead with that. However, if the head is high up and the position is not favorable for that of a vaginal delivery, then I would like to counsel her accordingly and shift her quickly to the operation theater, so that I can perform a cesarean section. And at the same time, I would like my midwife coordinator to inform the anesthetist and the pediatrician, so that the baby can be handed over to the pediatrician as soon as the baby is delivered. And I would also be very vigilant, so that we do not have any postpartum hemorrhage in this case, as she's a grand multipara, so her labor has to be managed actively. And so this would be my top urgent case. And then I have a patient in room number 8. She is para 3, and she has just delivered, and she's having retained placenta with a blood loss of 1700 ml. So that is a major postpartum hemorrhage she's having. So she would be my top priority as well. So in order to handle this, I would instantly call my, inform my consultant, and if the people of the night shift are there with me, I would like them to give a come and help me with this patient, as there are two top urgent, as I can see as of now, in room number 7 and room number 8. So I would initiate the protocol of major postpartum hemorrhage and quickly try and shift the patient to the operation theater. And I would cite 2 intravenous cannulas to start the fluids and send investigations for full blood count, kidney function test, liver function test, and clotting factors, and at the same time make arrangements for blood for group and cross match. And so I need to liaise with the blood bank and also with the hematology unit. So this patient is taken proper care of, and I would ask someone to do a contemporaneous noting of this as well, and I would raise an incidence of this case as well. So, and then I would go to room number 9. Room number 9, I have a patient who is a second gravida. She has a previous cesarean section at 37 weeks, and that was a section for anterior placenta. No, this pregnancy, she has an anterior placenta previa grade 4. So I need to check the consent, whether consent has been taken, whether the blood bank has been involved, and whether the pediatrician and the anesthetist have proper knowledge regarding this patient. And I would also like to get some background information regarding this patient as to what her previous cesarean section was, and whether it was a placenta previa, and what was the type of incision that was given, how was her recovery, so that I can manage her adequately. And I would also like to keep the radiology department informed in case we require any intervention radiology maneuvers to do in order to control the bleeding. If at all there is one, I should be completely prepared to tackle this patient, as she has been admitted in the unit from 35 weeks of pregnancy. So, so just to sum up, my top priority at this moment would be room number 7 and room number 8. And the others, as I've mentioned, would be the semi-urgent as of now. And once I have tackled these patients, I will go to each room and then apologize for my delay and take the necessary measures if anything has to be done. Thank you for your time.
Okay. Yeah, thank you. Right, okay. So just 55, 56 seconds left. Okay, so if you're doing labor ward prioritization, doing 3 rooms, and you have finished all the rooms and the bell hasn't still gone, I will be worried. I will really be worried. First of all, it was very nice, very good. You know, what you missed completely. But the way you described that was excellent. So yes, it needs to be, but it's very important here in this particular station. You must say that this is a handover I'm taking from my other duty of the patient. So I'm going to follow S bar. Yeah, so S bar word must come out here because that S bar was particularly designed for the handovers. So then you can start from by saying the situation is this, I want this background information, and my assessment is this, and then we need to do this, their recommendation thing, okay? So you did almost all the rooms absolutely fine, but I mean, you did talk about the partogram. You wanted to know when was the last examination and what was the finding that would like to do, but you completely forgot the fetus, baby in every room. Would you not like to look at the CTJ, Arena? The rest was fine, absolutely fine. Yes, the background information, the situation is this, induction of labor at 38 weeks for IUGR. So you will say, so, you know, I want to have a background information here. So the background is obviously, yes, first of all, being stillbirth and what gestation the stillbirth was, what was the cause of the stillbirth, and has been, it says IUGR. So what exactly you will review, you will say quickly, I would like to have the information about the, you know, weight of the baby and about the reason again for IUGR, what is, you know, there's some maternal complication like, you know, hypertensive or preeclampsia, and if she is, what is her current and the recent blood pressure and proteinuria. And then, and you know, what is the CTJ? and ask what is the CTG, and then ask, can I have these? Then you can take a decision upon, depending upon whether we can delay our loss. And if the CTG is fine, and if she's even hypertensive and protein due, if she's stable at the moment, she's doing very well, and she's not on preeclampsia protocol, then we can wait. Yeah, so inductions can always wait, but yes, the safety point is you must ask the maternal and the fetal both condition or any complications to make sure that they can wait. All right, so we will delay that induction. The thing I will recommend is absolutely fine. You can go room by room, and then at the end you need to tell them what your priority is. The first room priority wise is this and this and this. So I will suggest that you start from start with the emergencies. Yeah. So there are clearly 1 or 2 rooms where maybe some emergencies. So usually, I mean, there is one room where is maternal emergency in appointment that there is an imminent risk to the life of the mother, and there will be like 1 or 2 other rooms as well. There can be risk of life to the baby. So if you keep that in mind, one emergency, 2 really some urgent thing and something like that. Yeah, so you need to know that. And you can't know that unless you ask for CTGs. So I will say when you're preparing for those 2 minutes that you talk about when you enter, you can say my first priority will be room 8 because there's there's a hemorrhage there, and we'll initiate the protocol of BPH. And then you will say we will initiate the protocol, we call for help, and we'll ask them to call my consultant, anesthetist, and the team members, and then to approach the patient to say start from ABC. Patient is conscious, and it says the blood loss 1700 mils already. You would like to know from what was the reason of this blood clot, atony or what, and if she's still retained placenta, so obviously she needs to be immediately transferred to theater. Yeah, but after ABC, like airway obstruction, if she's conscious, then to explain her, quickly that we need to remove this placenta, putting her under anesthesia, and then there can be risk of bleeding, and then you need to just quickly tell that we will be prepared to do give her syntocinon, and then drip of syntocinon, and keep her under close observation for some time after the delivery of placenta. Okay, so that's why you can just simply say protocol. When you say protocol and just the first few steps like ABC, 1, 2 cannulas, blood, explain the woman, shift to the theater, and then we will manage accordingly. That's enough for the time being. At the end, if you will left the time by doing the other rooms, then you can add up to your emergency patient if you would like to do so. But at this station, as long as you have done these safety things and about transferring, it's important that if she's not in theater already, we ask them to get her to theater now. Okay, while you take the quick this one, and your consultant needs to be here. And then yes, after that you can go. If there is no other quite urgent room appearing here, then you can go for room by room. So room 1, we talked about that. So, and then room 2, again the same way. She has been induced post-day first attempt, and the second re-induced this one, and now she 3 to 4 centimeters. Background information, again, I will strongly recommend never use the word that I will assume. We do not assume, and that's the main reason when things go wrong, when we assume things. Yeah, so yes, you are right, she is low risk pregnancy, and that's why she has passed the dates. We induced, it didn't succeed, but then we waited for another 24 hours but we cannot assume. Things might have changed in last few hours. Yeah, so all you need to say is, so this has been, so I would like to take any other, about the any maternal or fetal complications. And again, partogram, when she was examined last time, what are the contractions? So can I have a partogram and CTG? So have a look then. When was the last examination? Does she require another one? No, if you would have asked me the CTG here, I will tell you that she's having, consistent variable decelerations, and her membranes are still intact. And the examination is just done now. So now you see your plan is going to change here. You need to tell now, you will send one of the midwives to, see this, and then you can send your ST3, or if the midwife can do ARM, then we see we need to do the ARM, put this woman to the left lateral positions, pass the cannula, start her on fluids, and then observe the CTG. And if there are any concerns about the CTG, then to inform. And then next one is empty. Okay, room 4 was your 2 previous cesarean section, elective sections, and on list for tomorrow, And I won't classify that as a semi-urgent. Again, if something has just changed recently that, yes, it was important, background information, what was the indications of previous two cesarean sections, what was the placental position in this pregnancy, were there any complications, any problems in the recovery of those cesarean sections, what were the weights of the baby, this cesarean section, have there been in this pregnancy any maternal and any fetal complications, or any concerns about the growth of the baby or the well-being, and then if that just be this indication is just because, then what is the placental, I would like to know. And she's for list tomorrow anyway, so she's for elective list, so that's fine. Now the one thing we need to sometimes few things we need to apply just for the sake of common sense, right? So she's for elective cesarean section for tomorrow list. Why is she on labor room? Yeah, why she's on labor ward? She should be in antenatal ward for tomorrow. All right, so this is something I will be alarmed. Okay, if she's for elective cesarean section, I mean, what she's doing here? Is she placenta previa this time? Is she, and that's why she's bleeding, that's why she has been transferred down there. And if she is, are the bloods available? So this one little information, when you think a little bit, that can change the whole scenario. Yeah, so it's very important, to pick up these little things. Well, they're not little thing, but for the common sense, to be alert. Room 5, 39 3-day spontaneous labor, and every woman who is in active labor, in addition to receive background information, you were good to ask about the background information the way you summarize as well. Always must ask the partogram and CTG. Okay, so this woman's CTG is late desaturations. Yeah, there's no other complication, nothing whatever. She's in spontaneous labor. She's 4 to 5 centimeters, and their examination was like 2 hours ago. No, she's having late desaturations. So now you can see what your plan absolutely changes here. You need to send your ST3 in this room immediately and examine her, and then do fetal blood sampling on this woman, and then inform you immediately about the results. Okay, so we can then do progress. Room 7, Gravida 6 para 5 spontaneous labor meconium stain liker at 6 centimeters. Background information, yes. No, you need to say the risk factors initially. You need to recognize she's a multipara, high risk of PPH. Then you need to ask about the background information, any other complication, maternal or fetal complications, or any concerns about the fetal growth. And meconium stain level, what is the thickness of the meconium? What is CTG? Again, when was she examined? Yeah. So if CTG is just a meconium stain liker and the CTG is satisfactory, we don't need to do anything. Just ask the midwife, one of the senior midwives over there, send her to continue with the CTG and monitor for the progress, and obviously be prepared to do active management of the third stage of labor. So give her syntocin on it at the delivery, and then start her 40 unit syntocin on trip. All right, so that's about that one. Room 3, the next room we have already talked about. The last room, the last room about, again, placenta previa grade 4 tomorrow list has been inpatient from 35 weeks. So just a quick things again, if she's not bleeding at the moment, she's per list tomorrow, has the blood been, cross-matched and is present in the fridge, is that up to date, and then, the CTG for today, satisfactory. And then she just, because she's bleeding, she's placenta previa, she must be bleeding probably. That's why she's in a labor ward as well, waiting for cesarean for tomorrow. All right. So the same way, if any elective cesarean section is sitting on the labor ward instead of antenatal ward, it's important to ask why.
Thank you, ma'am.
Okay. Right. Who is next? So Pramila says she is.
Next is Lubna, ma'am.
Okay, Lubna. Thank you, Pramila.
Thank you, ma'am. Dr. Sophia, please, as regard the assignment of the doctor, like S3, Y2, whom will be sent to each room?
Sorry, I couldn't quite clearly understand you. Can you speak again, please?
Dr. Sophia, as regards the doctors, which one I will assign for each room? Means ST3 for which room?
Yeah, so we said, so the first room we said, if her blood pressure, if she is hypertensive and stuff, if she's stable, we said we will send one of our midwife there. On the room 2, who's 3 to 4 centimeter with variable decelerations. Again, one of the midwives in this room to continue CTG, left lateral position fluids and do ARM. Room 4, because she was having, room 4, room 5. because she's having, she's 4 to 5 centimeter and CTG is decelerations. We said we will send room our ST3 to go and do fetal blood sampling. Room 7 is with the midwife. If the CTG is fine, then this would be and the rest of the staff, should be managing the retained placenta and PPH.
Sorry, doctor. Room 5. CTG is showing deceleration, but it seems like low risk case. Are we doing CTG for such cases? Room 5 only.
Where does so where does it say she's low risk? Does she say? She's not.
No, she didn't say, but
Yes, it doesn't say anything on the label on the board, so we need to ask. That's why we want background information. Okay, so when you will ask, has there been any maternal or fetal complications and concerns about the growth of the baby or something, they will volunteer you then some information over there if she's on CTG.
yeah, so we have to ask for any risk for all cases.
Yes, so background S bar, you must follow for every patient room. This is handover. When you're taking handover, you do it exactly according to S bar. This is situation, background information, maternal fetal complications, how long she's labor, is she's labor, when was the last examination done, where is can I have the partogram, and if there is any CTG. All right, so that information will be given to you.
And FY2, what is the job of FY2?
So FY2 are the junior doctors who are in the second year of their training. They do like 4 months rotation in everything, so they are very basic. You will utilize your FY2 for your PPH patient. She can, do help with the cannulas, fluids, and what else is required. Or if there was some other room where we need to pass the cannula, start fluids and stuff, FY2 can go there. So FY2s usually what they do is FY1 and FY2 because they are in your unit only for 4 months rotation. So they can do the prescriptions, they can do cannulas, fluids, GTOs like discharge letters and these type of things. They won't be able to do any particular obstetric skills, like they won't be really quite able to do the vaginal examination and tell you the findings or do ARM or interpret the CTGs. Although they have the basic knowledge, obviously they get trained in that one, but you won't send them for that type of management.
Hello, Dr. Satya.
Yeah.
I just have a question.
Yes, please.
Ma'am, when there are two emergencies, like in room number 7 and 8, what I said, can that be said, or do we have to call our consultant only? Like
For the
I
PPH,
said,
we have already, because of the PPH, we started from there by saying, I will initiate the protocol and call for help. Please call, we will call the consultant, both consultants, anesthetist and obstetric, and the consultant. So the consultant will be there. Room 7 is not an emergency unless if they have given you, if the CTG is abnormal. Otherwise, room 7 is not an emergency. We will need to have proactive management, active management of the third stage. But yes, if CTGs, and it can happen, there can be 2-3 rooms basically, where in some rooms you may need to do require emergency, some outlet forceps, and maybe somewhere some fetal or something is required. And then one major emergency. So you are calling consultant already here.
Is it okay to say that if I need help, then I can ask the people on duty at night to give a hand as well? Is it okay to say? Or
yeah, so the other day, last one when we did, there were 3-4 scenarios this type. There was incomplete information that somebody was coming with headache and hemorrhage, somebody was PPH, then there was another breach, undiagnosed breach in labor, and that we discussed that, that if all of them are actually the major PPH, okay, the consultant is there, they will do that. Then we had one, if there was a preeclampsia as well, ST5 need to go over there. And if then the breach actually, or some other abnormal CTG, where again ST5 and consultant input is required, then yes, you are asking your night team consultant to stay back, and they won't leave. I mean, you won't even, but for exam point of view, obviously you need to say that, but obviously in real life, obviously they're not going to leave it. Yeah. And it's not that they are standing, the ST5 is standing here and their night consultant is at home, your consultant is at home, however, and this all is happening in the clinic. The one is in preeclampsia, one is PPH, and that ST5 is actually waiting for you to arrive and take over. Those things are already happening, but for exam purposes, obviously you need to tell them. So yes, the night consultant can stay if it's a morning time, and even if you require more than that. In rare circumstances, sometimes it happens, everything goes mad. Everything decides just to go mad, absolutely. And then the morning, if it's a morning, then we see the whole gynae team is around. Yes, they have their own, the consultants, they might have their own elective lists or clinics to do. But if you require, if there is some abruption going on, there is some severe preeclampsia, there is some, you need to use 2-3 theaters, then you do call from the other consultants as well, even they may not have the night or day on call anyway.
Thank you.
And then we are doing PPH management, and we need to do the cesarean hysterectomy or PPH management even when we're doing, atony or whatever is going on. That consultant will call another consultant as well shortly, like after trying a little bit, like if you, 15, 20 minutes and you feel it's not coming, you will call any other consultant, one other consultant to come up as well to help, and then you take a decision to do cesarean hysterectomy.
From last May, there was one question of MRSA positive, MRSA positive. So in that case, what exactly examiner expects?
So if it says, well, if somebody is MRSA positive, then obviously they just need to use their PPE, and she will be given the antibiotics, and the care will continue. You obviously, again, just the PPE and all the protocols of infection prevention. If it says some patient has been transferred from their room, like say room 3 is now empty, like the patient is just MRSA positive and she's transferred to this, and then okay, that room needs to be cleaned according to the protocol for patients of MRSA. So MRSA is nothing, there is nothing hidden there. All you need to say is obviously they need to use the appropriate PPE.
And doctor, can we just start up because here some patients may be Rh negative also, so they may require anti-D. Some patients may require some additional like a Jehovah's Witness and all. So can we just make a general statement that I will look for all the patients' blood group background information?
No, you won't. You can't. This handover takes place about in 10-15 minutes, so you can't say that for every patient I will say, hand on a minute, you stay here, night, tired, ST5. I'm just going to have all this information about the basic information as well. If for a woman, she's in a major PPH, yes, in that one you can say, but Jehovah's Witness as such won't be any important thing here, because that's a secondary step. When we are going to give her, say, as we said, like for that woman who goes into PPH or something, yes, when we will do that, then we will check, if the need comes. This is just a quick plan. This is an emergency quick plan. This is not about talking about NTDs, and you need to imagine this is you are taking the handover from your night team. You all are standing on the station on that board, looking at that board. They are tired, they need to go and sleep. And then you need to take over and start managing the patients. So it's not simple session taking place. No. You all do that every morning, this handover, don't you?
No.
You don't
So
do.
nothing to be mentioned. Nothing to be mentioned. Just for just touch the. In short, we have to just touch all the rooms.
Yeah, appropriately the way we said, situation, background, assessment, and recommendation. The first line, immediate plan.
Okay, only first line. Okay.
Yeah, who is
And
next
ma'am,
now?
MRP we can do. MRP as ST5 we can do.
Yeah, you do as ST5, yeah. Who is next, please?
Okay.
And be careful, you guys use these abbreviations, too many of these abbreviations. Please make a habit to say full word. In examination, if you will say these, you might have a little bit of risk of being penalized. Unless they are very, very, very common, like PPH, APH, MRSA, these are okay, CTG, these are okay. But be careful, these sometimes they are not very common and recommended abbreviations. We just use as a, I had to focus really to understand your MRP, what that could be. So don't do that in exam, yeah? Just be careful. Next person now, please. Hello? I can't hear. I can't have any.
Hello, Dr.
Hello,
Sophia.
Dr. Singh. We can hear you.
You can hear me, right? Okay. Okay, so who is next? What's wrong with my laptop? Who was the next one to do this station? Pramila told us before she left. Look at that, your list, girls, please.
It was Lubna.
Lubna. Yes, Lubna. Is Lubna not here? So on the list, who's next? I mean, be active, girls. Please have a look yourself. I mean, you shouldn't really be told to tell. So who is next? If that person is not there, go the next one. Dipti? Dipti? Hello, Dipti.
Yes, ma'am. Yes, ma'am.
Okay, so this next one is for you.
This is for me.
Give me 1 second now, because there are some stations which we have done in the last session already. This is not the presentation which I was supposed to have. Okay, let's do one more labor ward.
Okay. Ma'am, just to start with labor room prioritization, it comes like a palpitation starts. I don't know why.
It shouldn't be. Just practice, practice, and practice.
Can I start?
Yes, you can start now.
Hello, I'm Dr. Dipti here. I have taken the handover at 8 o'clock and I'm going to represent my labor board prioritization on the basis of ASBAR tool, that is situation background, assessment and recommendations, and patients and fetal well-being would be my topmost priority. I have 3 patients at a stretch on topmost on emergency list. One is room number 5, that is Leslie. She has been pushing since 7 a.m., but her fetal heart rate is so about concerns, and CTG is also abnormal. So for these patients, I have to arrange either ST3 to just take care of her and to go for the instrumental delivery. Before that, introduction to the patients and debriefing to the patients about the interventions assisted vaginal delivery should be mentioned, and if per abdomen per vagina, the patient should be fit for that instrumentations. If head is very high, in that case SOS cesarean section should be explained. And if my ST3 can't manage, then he or she can take the help of me or my consultant. My second patient is of concerns that where I would like to go, that is room number 3, because she is delivered cesarean sections with severe preeclampsia. She had a major PPH, and because she had 1200 ml blood loss, 4 units already been transferred, but I am concerned about the urine output. Still, it is 20 ml for 3 hours. It is a really worrisome point for her safety. So I will consent to my consultant and my anesthetist doctor, and I will just follow the protocol of the major PPH, and I will just review her notes and review her the investigations, mainly that full blood count, coagulation profile, bleeding profile, liver function, basic liver function test, and renal function test, and would like to find out the cause of such a severe oliguria, and if need, I can involve my hematologist and the intensivist as well. About the third, my topmost priority will be my room number 2. She is Mrs. Kaur. She is a precious pregnancy, IVF pregnancy with 4 centimeter, and she had mild preeclampsia, but now impending symptoms. So if my ST3 is free, I can send her there, or I will, or I can send ST2. And I will just review her notes, and I will just take the background informations, and I will just rule out whether there is no impending eclampsia. In case if it is needed, I will start the protocol for myself after informing my consultant, and I will check the basic blood group, and I will just check her other findings also. Is there any background partogram or CTG, ma'am?
For room 2?
Room number 2.
Yeah. So she is 4 centimeter already. There was just done examination just now, and the CTG is satisfactory.
Okay, so worrisome point here only that impending symptoms. So we will just keep her continuous monitoring of blood pressure and vital signs, and we will put her catheter and input output chart also will start. I will assign one midwife who is a senior midwife will make the records of all the vitals, and the continuous CTG would be provided to her. Room number 1 teller is a semi-urgent according to me, because it's undiagnosed breech at 5 centimeters. She's quite in early labor, quite in active labor now. So I have to just take the handover by my previous team that whether any options for the breech delivery has been discussed or no, whether she is willing for the vaginal breech or she is ready for the cesarean section, what is her decision, and all this I have to review. Accordingly, I have to take a call, and in case if she's ready for the cesarean, then I have to alert the OT team. I have to manage with the WHO surgical checklist, pre-op, intra-op, and post-op. I will follow that, and I will just keep my pediatrician team also alert, because this baby may require resuscitations immediately after the delivery. In case if she's going for the vaginal breech delivery, then accordingly maybe ST3 or I can handle this case, keeping my consultant in the loop and traceable, as well as I may have to take her help. That's all. And room number 4, She has Sartha, she has meconium, but she has come from the midwife unit. So I have to check her partogram CTG, and I have to review her case. How is the meconium thickness, whether it is a really significant meconium staining or what. And I have to assign one midwife for the continuous CTG monitoring and all. And in case if her CTG is satisfactory, I will just follow the regular nice guidelines tips for that. And in case if she's going for the abnormal or pathological CTG, then I have to send her for FBS and fetal blood sampling, and then accordingly I will take a call. Room number 6 means she is for waiting for the ECV, so I have to send my ST1 or ST2 for the consent. And in case if and she can wait after I finish all my emergencies, I can go personally. I will just inform my consultant also. I will just go through her notes, and I will see whether patient has been well explained about ECV or no, or she is totally blank about that. And I will clarify all her doubts, and I will mention that if she is fit for ECV, then I will go ahead with that.
Okay. So that, I think, I mean, obviously this is one of the recalls which is circulating everywhere, but I don't think it actually is complete. There must be some more rooms there somewhere anyway. Anyway, so for these months, thank you. You did it well.
Thank you.
So I like the way you started.
Ma'am, is it my fast station or fail station? I have very much palpitation for this labor.
Wait for your feedback. Wait for your feedback, sweetheart. Just wait for your feedback. So you started nicely when you said, like, I'm going to take this according to S bar, and the safety will be my priority. That's fine. But during the course of following that, you didn't go according to the background. You didn't want to. You didn't ask me the background information. Yes, you said I would like to, but then you didn't ask where is that background information. So without having the background information, we can't, go ahead. So just one word I have written here. I think that was about room 2. You said it's precious pregnancy. Was that the word precious pregnancy?
Yeah, IVF conception and impending symptoms, meaning I understood impending eclampsia.
Mm-hmm.
So, and it's IVF pregnancy, so,
mm-hmm.
and twins also. My God.
So, no, I just say I wanted to understand the word precious. You said precious pregnancy. What
just because it's IVF, so I use that word. We shouldn't, I don't know.
Okay. So you think she conceived with difficulty and stuff. All right, okay.
Yeah, with that concept.
All right, be careful not to use that word here for UK exams, because here every pregnancy is precious. So we don't use that terminology. Okay. I understand your perspective. Basically, you're right. I can understand in the idea this word can be used. Okay, so so background information. There was a quite lot to the background information, which we see because we didn't ask, it won't be delivered to you. Because I'm tired, I'm ST5 of the night team. I have been absolutely naked and tired at the moment. I just want you to take this responsibility. I go to sleep. So honestly, it's not that I want to put you in trouble. I just not able to basically volunteer, give you a lot of details if you don't want them. All right, so please ask me those details. So we can start according to the way you went. So you started from the room 5, full pushing since 7 a.m. and the fetal heart rate 80 beats. Now CTG means abnormal, obviously 80 beat, and then we need to know is it bradycardia. Now the background information is important here, and you said you would send your ST3 here. ST3, we don't even know whether ST3 can manage with this lady or not, right? If it's only a fetal 80, it was one late deceleration or just a deceleration where it once went up to 80 beat, and then after that it's like, doing okay or whatever. We might just some other decelerations, and she is fully dilated only, 7 a.m. means if it's a morning 8 a.m. it's only 1 hour she's fully dilated. Yeah, I mean, we could do so. If she is like the heart is at, sitting at +1, not even at 0 station, and there are decelerations. Unless you see the CTG, you can't know what we're going to do that. Unless you see the partogram, you can't decide who.
Here, ma'am, it is mentioned CTG abnormal. That's why I didn't ask.
Yeah, abnormal
Sickness.
CTG can be anything, you know, but you need to have other background information, no? What is Potogram? According to
Like
Potogram and other, yeah, so she's fully
what
validated.
kind of
Yeah,
since
how,
when also she's mentioned.
okay, give me one minute. So background information is, I won't worry about her maternal and the during pregnancy complications and stuff. This is imminent, the fetal. Let's assume it's even a bradycardia. Okay, so if it's a bradycardia, unless you take the background information, what is the station? What is the position? Yeah, if this position is +1 and the head is in right occipital posterior, your ST3 can't do anything here. You need to, everything you will leave, you need to jump for this woman because she needs, cesarean section straight away. You won't even try the instrumental delivery for this woman if the head is sitting at +1 and head being in right occipital posterior position. So that's why it's very important, you know, and this is what exactly you will do, won't you? You will do, examine, even before applying the instruments and what you do, you will ask and assess that information. So keep it natural, yeah, Dipti. Don't
Yes.
feel nervous. You say I start having the palpitations. No, don't feel it. It's not, they are just simple things which you're doing. So obviously what happens is here you need to deliver this baby. That should be the first impression here, right? We need to deliver
Yes.
this baby immediately. Okay, we need to deliver, then how are we going to deliver? Can we do just the outlet force? Yes, it could be as nice. We tell you, yes, the head is actually sitting at +3 or +2 or +3, basically. And obviously, if it's +3, then it is occipital anterior. Yes, send your ST3 immediately here. If there is nothing that dying emergency for you to go anywhere, just go and do outlet forceps delivery here. But then at the time, there would have been a situation, it's +1 or 0 and right occipital posterior, then you have to rush. This is category 1 cesarean section. Okay, so that's why the background information is very important here. But in this particular woman, yes, I won't be bothered about any maternal complications or anything else, because I need to absolutely rush for this woman here. Right, so that's about her. Then you went for your room 3, delivered cesarean section, severe preeclampsia, 2 a.m., blood loss this much, pro blood has been transfused, and then urine output is 20 ml. You said we will initiate the protocol of PPH. We don't know that PPH was 2 a.m. and it's 8 a.m. now. It's 6 hours ago she had a cesarean section. So we don't know whether she's still bleeding or not, what's going on. Yes, we need to have that information first, quickly. Again, background information, again, yeah, important. So from that one, okay, when it comes to the blood loss of 1200 mils, what was the reason? Yeah, what was the cause? She has some abruption. Did she have like atony of the uterus? We need to quickly know what was the reason for that blood loss, cause of that blood loss. And then, okay, transfusions have been given. So then the next one is she bleeding now? Yeah, is there any concern that there is ongoing bleeding? If there is, then yes, again, we are going to initiate PPH protocol. But if she's not bleeding now, and the rest of our observations we see from preeclampsia point of view, we need to quickly ask, is she stable from preeclampsia point of view, like her blood pressure and proteinuria, what is her? The rest all is, if the rest is okay, like she's not imminent going into eclampsia again, then you need to quickly ask them to, just have her, the recent bloods which were sent, like her flow per count, UNEs and RFTs and LFTs, and if she's on magnesium sulfate, and if, you need to quickly have that information. So urine output 20 mils is then, okay, so let's assume there could be 2 possible scenarios here, no? So one can be that she, the blood loss was, she's not bleeding, her preeclampsia and that stuff is under control as well at the moment. So you will say, okay, so we'll continue with that protocol, and then we need to try to find out the reason for this. So first of all, we need to immediately review her intake output fluid chart. What is happening, has that blood loss, the amount of blood loss and that all has been. So then you will also say, yes, you will look at the all the blood tests which has been done recently. Her renal function tests are very important. eGFR, her recent should be, and if not, immediately send it, because it could be acute kidney injury. Yeah, then we will need to follow the management of acute kidney injury, and we may need to transfer her to, she's high dependency unit, but we may need to then accordingly send. And if she's bleeding now, then yes, just again immediately start PPH protocol and start replacing the fluids, called the consultant, called the anesthetist consultant, called the anesthetist ST5. And hopefully she has 2 cannulas already, catheter, everything should be in place, and then you just start from ABC again. But that, if that is not, then you obviously need to say that we will then, this can be one of the complications. It could be acute kidney injury. So obviously you need to then immediately send the investigations and speak to your consultant, and then get the advice from the urologist as well. Then you need to manage on that basis, right?
Madam, can it be max self toxicity also?
Can be, yes, because she's on magnesium sulfate. That's why you need to send all those bloods quickly. Just ask what were the recent results, because in this woman you will be repeating bloods after every 4 hours. So just check what are the results of those bloods, and then accordingly. Yeah, so that's why this background information is important. Once you will list, I want to know these, then ask the examiner, do I have the results of these? And if there are some clear results given, then you obviously will understand, okay, that's the reason. If it's Mexel or whatever is going on, then you can talk about that management accordingly. And if it's not, they say, well, no, they were done at, they were sent 1 hour ago, but the results are not back yet. Okay, what were the previous results? And if not, then send immediately requesting emergency results to the lab, and then proceed accordingly. And involve your consultant here, get the advice from the urologist immediately as well. Room 2, IVF, twins 4 centimeter dilated with pending symptoms, mild eclampsia on admission. We don't know when she was admitted, yeah? Mild eclampsia was at that time, okay? So how long she is in labor now? What are her recent blood pressure and proteinuria? Has she been on antihypertensives? Has she been on any protocol already? An impending symptom, what symptoms is she having? Headache, bloating, pain, epigastric pain, what symptoms is she having? And if she's having those, then she's imminent preeclampsia. Yeah. So obviously then you need to quickly talk about the current labor as well. When was she examined last time? What is the CTG? Okay. And then you need to, if she is, when it says imminent symptoms, it is imminent eclampsia then, right? So you need to immediately start the preeclampsia protocol. So you start, IV antihypertensive, you start magnesium sulfate. So you're going to just immediately start all these. Your room 1 was undiagnosed breech 5 centimeters 7:30 a.m. So you need to quickly ask, has there been a chance for the night registrar to speak to this woman? Has she been informed about this? And has she been counseled about the mode of delivery? And has she chosen? But it's unlikely probably, because it's 8 a.m. you're taking the over, and she has just arrived half an hour ago. So maybe the registrar may not have the chance. So we see that will be the woman then you need to, because if she's 5 centimeter and she doesn't want to go for breech vaginal, then she needs to be taken to theatre state by category 1 cesarean section. No, not category 1, sorry, category 2 cesarean section. Okay, so about the mode of delivery, then you will say we will discuss about obviously then the cesarean sections, risk of the cesarean section, and then we will explain. You don't need to go into the details yet. Just simply say for the time being the risk of the cesarean section, and then the vaginal breach and the complications and the risk of the vaginal breach. And then the statement was very dangerous when you said it will be your ST3 or you who will then deliver this woman. No, breach cannot be delivered by ST3s, okay? So, and you won't even deliver, even ST5 won't deliver the vaginal breach. You can deliver if your consultant is standing next to you. Okay, so what the guideline says, the vaginal breach should be delivered by the practitioners with the experience in vaginal breach delivery. So nevertheless, they are the consultants, right? So the consultant is standing to you, next to you. All right. So ST5, we don't expect you have that. And I mean, obviously there are more and more vaginal buds now. So unless you then say that as well, that I have actually done 4 vaginal breaches already under supervision of consultant, so I'm confident to do that. Then you need to say that I have done it. Okay. But there is no way, there is no place for ST3 here. But obviously you need to know again partogram and CTG of this woman as well. All right. Room 4, you didn't bother at all. She's 6. She was transferred from midwifery unit at 6. And why is she transferred from there? Something has gone wrong over there. That's why she's transferred over here. Yeah. So
I assume maybe because of meconium she is transferred.
Yeah, meconium could be just another reason maybe as well. So is she on CTG then? What is partogram? What was the last examination? What is the CTG? I think it's about the same we did in the last one maybe. And you know, that's, yeah. So waiting for ECV one, that's fine. At the time being, just ask the midwife to that, you know, they do the CTG and then tell you know the consultant will come, and we have like these 2 emergencies going on. So even the consultant even arrive, she may have to review or manage those emergency first. So there may be some delay in her ECV procedure.
Madam, who will take ECV consent? ST5 can take or no?
Yeah, of course. ST5, your ST3 can take, even ST2 can take the consent. Okay. Consent can be taken. The person who take the consent, that doesn't mean that person should be capable of doing the procedure as well. Consent can be taken by any person who has been trained to take the consent and who's aware about the procedure. He knows how the procedure will be done and what the complication and there is. But necessarily that person don't need to be competent to do that procedure. So even ST3 or ST2 should be even fine to take that consent, okay?
But ECV will be done by consultant only, no?
ECVs are done by consultants, yes. Right then, so so that's about your this labor ward. So the labor ward, please keep it very simple and easy. Just think simple and logical. The way obviously you people have been told about these labor ward management, unnecessarily the people have made it so complicated that people, as soon as you see the labor ward, you all start worrying and confusing that there need to be some hidden, I don't know what. No, just simple handover, please. Assume you are on the labor ward taking handover. What you need to know here, and if I'm sending this person. Who is next?
Thank you, ma'am.
Rabab is next.
Rabab is next. How many stations have we done? 3?
3.
Okay. No, this is not the presentation I was supposed to have today. Is this the one I have sent you guys? Okay, Rabab. So your station is, I'm going to give you the station because it's not like I don't have some slides over here. I don't know what went wrong. So you're asked to, so you're ST5 and you're asked by your midwife to see Amelia Wood in room 3, who is Gravda 3, Para 0 plus 2 previous miscarriages. She's 38 years old. And she's 39 weeks and 2 days today, and she presented this morning because she was unable to feel fetal movements, for a few hours. Midwife could not find the heart on CTG, and then she requested you to come down to do the scan. You have done the scan, and let's imagine somebody else has also done the scan, and the fetal heart is not there, so it's a stillbirth. So your task is to break the bad news to this woman and then explain her management. Yeah, is that clear? Yes, Rabab? Hello, Rabab.
Next
Rabab
is
there?
Sapna, if Rabab is not there.
Sapna? Hello, Sapna, are you there?
Hello.
Yes. Is this Sapna?
Yes, ma'am.
Yes, Sapna. Okay, Sapna, so this question
Yes,
is for you.
yes, ma'am.
Do you ST5 asked by the midwife? Yeah.
Okay.
To see Amelia Wood, 38 years old, Gravda 3 para 0 plus 2 previous miscarriages, 39 plus 2, low risk pregnancy otherwise. Presented this morning because she was unable to feel baby movements. Midwife could not locate the heart on CTG. And your, say you're off, one of other ST5 has done the scan and, they couldn't see the heartbeat, and then you came down as well to do the scan. You can't see the heartbeat as well. It's a stillbirth. Task is to break the bad news and counsel the management to this woman.
Okay.
So you organize your thoughts, write down bullet points, how you're going to approach this session. So it might slightly go above 2 minutes because I'm just rushing down to get a cup of coffee, okay? It won't be long. Yes. Hello?
Hello. Hello.
Yes, hello. Can you hear me?
Yes, ma'am. Okay.
We can't hear you.
So, hello. I want to may I perform? Hello.
Yes, hello.
Hello. Hello.
Yes, hello. Yeah, there's quite a lot of interruption in your
Yes,
voice. I
ma'am.
don't know it's you or it's my. Yeah. Yes, start, please.
So shall I start, ma'am? Okay. Hello, I'm Dr.
Yes, now
Sapna,
it's
one of the
better. Yes,
doctors in
please.
the clinic. May I please confirm your name and age?
My name is Amelia, doctor, and I'm 38 years old.
Okay. So Amelia, I can see that you came today morning with reduced fetal movements, baby movements, and you were seen by the midwife. And I can see that midwife couldn't locate the baby's heart, and she has sent for a scan. And I have also got the scan report, and I have also done a scan myself. And we are here to discuss regarding your results.
Yes,
Okay.
doctor, please, can you tell me my baby's okay? I'm really worried.
Uh,
I'm just extremely, please tell me quickly about my baby.
Yes, Amelia, I can really understand your anxiety. But do you have someone with you? Would you like your partner to be called in when I discuss the report?
Well, he's not here. I gave him ring. He was at work. He's on the way. But please, I can't wait till then. Please tell me, is my baby all right?
Amelia, I have done the scan, but the baby's, what I can find is the baby's heartbeat has stopped. Um, and that means the baby is no more. So
What you saying,
this,
doctor? What are you saying, doctor?
yes,
It can't be
Amelia,
true. It
I
can't
can.
be true, doctor.
Amelia, I can see that you are upset, and this is not an expected news at all. But we had 2 scans done, and we have confirmed that your baby's heartbeat has stopped, and baby is no more.
Oh God.
I'm really sorry for this upsetting news.
I can't believe this. I just absolutely can't believe this. This happened to me. Oh, my baby.
Amelia, would you like me to ring up your partner?
Oh, I can't believe this. I can't believe this. This can't
I'm
be
really
true.
sorry for this news, but it is true that this has happened, and we do not know
How can
exactly
this
why it
happen?
has happened.
How can this happen, doctors? How can this happen? I was told my baby's fine, I was told my baby's fine and I'm doing okay. I have 2 miscarriages. I had 2 miscarriages already, and I was just saying to the midwife, you need to do more scans on the baby, and you need to do some more tests on me as well, just to make sure that nothing goes wrong with the baby. But she kept saying to me, is everything is okay? Baby's doing all right. Now you're fine. There's nothing wrong with both of you, and we don't need to do any of the tests. But clearly everything was not right. It's all you guys' mistake. I lost my baby today. I'm just gonna sue you guys. I won't spare anybody. I'm just absolutely gonna sue you guys. I can't believe you guys have killed my
Uh,
baby.
Amelia, I'm really sorry that just as you feel so low and so depressed, me and my team also feel the same way, because what I can see from the notes is that you have been doing very fine throughout the pregnancy. You didn't have any complications. It was an absolutely low risk pregnancy, but suddenly we have lost a baby. So it's a real shocking news for all of us. Um,
Hmm,
Amelia, would you like me to connect with our counselor
hmm.
so that you could feel better? Amelia? Amelia, would you like me to connect with the counselor? Are you okay to continue with how we take forward this pregnancy now? What I can do is I can some the can some the touch with support groups. Like we have certain groups called SANS, where we have women who have undergone your similar condition, so that you might feel better talking to them. Would you like me to do so, Amelia?
I don't want to see anybody at the minute.
And see that it's a really shocking and unexpected news, but we need to, um, like, can we offer you what, how we can move forward now? What do you say, Amelia? Or would you like me to arrange or schedule another appointment with your partner? Or would you like me to call your partner so that he can be with you? You can discuss among yourself what is to be done.
He will
What
be
do you
here
say,
any
Amelia?
minute. I have called her. I did when I, came here. So he will be coming here any minute now.
Okay, okay, that would be of great support to you. So, would you like me to wait until he comes to discuss regarding the management,
No, you can tell
or
me.
would you like?
You can tell me what happened now. Yeah.
Okay. So, Amelia, I know that this is a really a very sad situation, but now we need to think what can be done.
Yeah.
So, like now, since we have to find out why this has happened, so for that we can do certain blood test on you and your baby as well. Once you have given birth to your baby,
Okay.
and so what we need to consider now is send for certain blood test and arrange for certain for adequate, that is, group and save your blood. And we try putting you into artificial pains, that is to open up your womb so that you can deliver your baby. And then once baby is delivered, baby can be sent for certain investigations, and also your blood test can be taken to see what has happened and why this has happened. And more than that, these investigations will give information, um, very important information, so that if at all in the next pregnancy we have to prevent these, it will provide valuable information.
Okay.
Are you with me, Amelia?
Yeah. Yeah. Yeah.
Okay. So I'll be talking with my consultant regarding this your situation, and also I'll get your get the consultant talk to you and your partner regarding this and how we go forward now on. Usually we start off labor with certain medications which are given orally, and 48 hours later we start giving you medicines to open up your womb, and these are repeated at periodic intervals. And once this happens, as you go into labor, it will be as in a normal pregnancy, in any other normal pregnancy. And once the baby is delivered, we'll you can hold the baby, and you can take photographs. You can preserve whatever materials you would like of your baby, and we'll also arrange for the investigations on the baby. Okay.
Okay, your time is over.
Okay. So I'll talk with the consultant regarding this and arrange for a meeting with you both. Okay. And meanwhile, I'll connect you with the counselor and the support group as well. Thank you.
Right. Okay. How you feel about doing this station?
I don't like doing this station. In the real scenario also, real life also.
Of course, yeah.
This one also, exam also.
It is absolutely horrendous. I think you did pretty much good, staying calm, staying patient, not rushing. In the beginning, I did feel, when you just said to me, we can connect you to the counselors and all that stuff. Counseling is not just for that time being, like it's not something obviously some acute remedy like a medicine that we will give you painkiller now and you will get relief. So yes, we will arrange the counseling, and then the counseling service is separate service as well. In the hospital we just got the bereavement counselor, and that's like 9 to 5 kind of duty as well. In the night, if we need to call them, we need to call them from their own night rota. So counselor is not something which we can immediately tell them to say, offer them to say, would you like me to just connect to the counselor now or call the counselor for you? So that's not. I would say to start with, be a little bit calmer, a bit slow to start with. The sound should reflect that little bit of grief as well. To say, so when you came in to say, I wouldn't say, is it Amelia Wood? I will actually call here with the name. I will enter and say, Amelia Wood, my name is Dr. Shabin. I'm one of the doctors who will be looking after you today. So I will be a slightly different way of intro here. And then I will just say, so just to double check, would you confirm me your name and date of birth? But this is how I will be speaking very slowly. And then when she tells, then I will say, so, you can with you can feel the baby movements, and the midwife couldn't, don't say fetal heart or something, baby couldn't, the midwife couldn't find the baby's heartbeat. So, arrange these scans, which has been done, and have the scan report with me. And then prepare her first instead of asking about the partner straight away. So say this scan report is extremely unexpected and shocking. Would you like me to call your partner or some family member and friend to be here before we discuss this scan report? Yeah, literally these type of tone and these type of words, because if you are shocked and, the way you're saying we are also shocked or we are upset, if you're empathetic, your energy needs to be very low as well. And it will go low, when we come, like it goes low. So energy needs to be low in this station. So this way, and then when we say that obviously she's going to get angry, she probably will get distressed, she might get restless to say, is my baby okay? Please, doctor, tell me quickly what's going on. Is my baby all right? So don't then, lengthen that process or anything, like just simply say, well, the scan, they have not been able to, they have, the scan is done and, the baby's heart has stopped. This baby is no more. or even this baby has died. I'm afraid this baby has died. Okay. She's going to scream, cry, different people different. Some people might choose to, they go numb, don't speak anything at all. You don't need to rush now to say, if she's screaming, she's restless, listen to. Literally go quiet for about 10 seconds at least. And 10 seconds is a long time, all right? So you need to slowly count in your brain 1, 2, 3, all right? At least, 6, 7 seconds. So then you say, because you're also shocked. So your nerves are not reacting very quickly either. So you need to bit, and then you will say, I can see this news is absolutely devastating for you. It's been quite shocking for us as well, because your pregnancy was going straight forward and smoothly. There was nothing wrong with you, nothing wrong with baby. So this is absolutely shocking outcome. Yeah, and then just go quiet. I'm not even starting to say her not to do or do anything. I'm also acknowledging and absorbing her grief with her first. Yeah. And then again, 2, 3 seconds, quiet. And then very slowly, just ask her, would you like me to, and don't call from Amelia and Amelia, yeah? You are sitting in front talking to her, so just simply say, because when we call by the name by saying Amelia, what that basically appears like is that we are actually trying to pull her out of her emotions and saying, listen to us, right? And we're not doing that. We don't want to do this at this stage. So just slowly again talk and say, would you like me to call your partner or some other family member to come here with you to see what she says? So it's coming or whatever, or even she's quiet, that's okay. If she doesn't say anything, which is quite expected, it's all right. Just give 2, 3 seconds again, and then go and then just speak again and say, if there are, obviously on online, you can't do this tissue paper and all that stuff. Just say, shall I bring you some drink for you? Some water or some tea? And then again, give a couple of seconds pause. And if she's still like quiet, if she's gone quiet now and looking at you, she start asking some questions, that's very easy then, particularly if she starts speaking and asking you questions, saying, even whether it's blaming, saying, I was well, she said you are well, the baby is well, all is well, and there's nothing else you need to do. I think that is the most easiest situation in this manner, because then we can slowly and calmly start answering her questions, and then we can smoothly proceed to the further management. I find most difficult when the patient is crying or they just go quiet. Then it's really difficult. And you need to be very sensitive in that situation. So so then you can ask her, if she's crying, then you can ask about saying, okay, so would you like me to give you some time here to come to terms with this news? Or you would want me to give you some information now, what to do from here? Yeah, again, this type of gap. In this situation, there isn't much for the investigation point of view you need to talk about. I won't even bring the delivery of the baby here, and you can hold the baby and you can take the pictures. This is a kind of increasing her trauma. Let her absorb the news first, right? So I won't be worried. This station is absolutely, completely about dealing the emotions of this woman. And then if she start asking you those questions by saying, she said this and well, then again, don't go into defensive. Don't try to clear it either. Just, when she says, you're absolutely okay, actually, just to be quiet for 1 second again when she finishes her complaint. And then say that you're right, that it was very straightforward pregnancy. You were absolutely fine. Baby was doing okay. And because there was no concern at all, we did not require any further monitoring or anything like that. Everything was going pretty straightforward. And then actually, we can start exploring basically and ask her a few things and say, did you feel unwell at all in last few days? So did you just notice this from this morning that the baby was not moving at all, or you did have any concern that the baby was getting slower, yesterday and these last couple of days? And do you have any fever, any cough, any chest infection? Letter answer. Have you noticed any pain while you pass urine? Any stinging, burning, or you may have noticed any foul smell in your discharge. Yeah. So after acknowledging, instead of I start saying and sorry, you were fine and we don't do this, I'm not going into defensive mode. I will just simply saying you're right, you were going so nicely and blah blah blah, and then just saying, so did you feel unwell at all or this? Yeah. So I'm just proceeding from there. And then after obviously asking, so you have done now here the information taking bit already. Yeah. That's your history taking about this. And if she says I was low risk, they said no problem. That means she's low risk. I don't need to ask basically her whether there any complications, any problems in pregnancy, you had high blood pressure and stuff. Yeah, just a common sense again. If we are saying and she says I was told I'm low risk, nothing extra needs to be done, that means it is. And in these particular circumstances, I'm not going to ask that question from the baby. I'm going to take it, okay? That everything is all right. Was all right. And then, again, slowly you say, so what we need to do now is we need to deliver this baby because if we will leave it longer, then there's a risk that the afterbirth can release some chemicals which can be harmful for you. They can actually make your blood go thinner, and that can result in quite heavy bleeding or even bleeding in different parts of your body. However, I mean, there is no rush that we should start that straight away now. We can leave it, till you come to terms with this news and your partner and your family. So how you feel about this? Yeah. And then you will say, no, if she says from there now, or if she has started engaging, then you can start giving her some idea. So you will say, so what we will do now, we will take some blood tests from you. Bloods for your to see the cells in your body, your liver, and to check the function of your liver and kidneys, and also send some tests to check for some particular virus infections with some those as well. And when you will feel a bit ready for the examination, then I would like to give you some speculum examination and take some swabs from there as well, because sometimes if there is some infection in the vagina, that can go up and cause infection around the, in the, that background of the baby, and that can also result, infection to the baby, and baby can die. And we will check your urine for any infections as well to try to, these tests will help us to understand what went wrong, what could be the possible reason. And we may need to take some blood tests from your husband as well, just to check for the genetic information from both of you. We call it karyotyping, just to check that was there anything wrong from the genetic material level. And then I will say, so we will send these tests. It can take a couple of days for these tests to come back. And sometime, even in spite of sending all these tests, we may not be able to find anything, any cause and any reason. And then, so after these tests, and when you have come to terms with this, then we will start your labor. So we'll give you internal examination to feel the condition of your neck of the womb, and then we might induce you, by giving some, putting some medicine inside, which will start opening the neck of the womb and also initiate the contractions. And once the baby is born, then we will take some tests from the baby as well. So, some blood from the cord of the baby, some swabs from the skin. We will send the afterbirth take some spots from the afterbirth as well to rule out any infections and for the information, for the daily examination. And then we can consider doing some detailed examination of the baby as well, which we will discuss with you at that stage. So do not use the word of postpartum and anything like that, or any emotional stuff from baby point of view you can hold and all that. At this stage, this is enough. Don't bring the sands and all that right straight away in the beginning when she's crying and all that stuff, right? No, at the end, if she has listened by this all information, then I can say from here now. So how you feel about if we arrange our bereavement counselor to come down and speak to you and, your partner and family, that might help you to deal with this grave slightly better manner. Yeah. And then if still the belly is not gone, you can say then I will also then, provide you some written the contact details of some groups. We call them SANs, like they are just like other parents and mothers who have also lost babies, like, circumstances similar to yours. That concludes your station. All right. That's all you need to. You do not. And if she keep going crying and crying and crying, that's absolutely fine. And I tell this to every batch. I had this station in my exam, and the women did not let me reach to placental examination. And even after just few tests, I will say something, and she will start crying again. And I was about to cry with her as well, and then we start again, and I was passed. I know obviously being examiner as well from the mark scheme and everything, we do know that's more about this examination. Absolutely decide, this is your role player who decides whether they want you to pass or not. Very simple, straightforward question is being asked from the role player. After that, the single question is asked from by the examiner says, if God forbid you were in real circumstances, would you like this doctor to say? And if she says yes, you are passed. And if she says she was horrible, absolutely not. I would never like to see this. And you're gone. You might have ticked off in your opinion all the list. Okay, so please, yes, listen this station few times too, because this does appear. If this was in not, then postmortem, baby postmortem comes. Right, so that's our next station then. So who is the next one? Please don't worry, whoever it is, just come.
Thank
It's
you.
fine. It's okay. We do understand these are difficult stations. Yeah, who is the next one now?
Is Pramila here?
No, Pramila is not here now. So she has put the list on. So can somebody just go through?
Yeah, because Pramila's name was next. That's why I was asking.
Yeah, Pramila
And
said
is Anila
somebody you can
here?
take my, yeah, she said probably Sadia, you to take, I think.
Yeah, I'm happy to take. And then Anila Sri can take the next, her own slot. Thanks, Anila, for
That's
offering
okay.
me.
That's fine. It's okay. Right then. Okay, so Sadia. Dr. Safia, what is the answer if she wants to sue? If she wants to sue at this stage and she says, you say, okay, if you feel to do so, that's absolutely okay. And we will give you the information and we will explain you the process, how to do it. We will facilitate it for you. That's just these two short sentences. Don't talk about the balls and all that stuff. No, just simply say yes, that's absolutely okay. If you want to do so, we will facilitate that process for you. So we'll give you all the information about the process and also the contact details, who you will need to contact and write. All right. Right. Okay. So first tell us, Sadia, how is your lady with cardiac arrest?
She's better. She had during cesarean section, just last night, fourth night shift, 6 o'clock in the morning.
Yeah. So what was the probable cause then?
We don't know. It might be amniotic fluid embolism because she did not have any grave medical condition. I mean, she was preeclamptic, but she was very, very stable, not even on medication.
Yeah, most likely reason.
But thanks for asking.
Yeah. So you should pass this station now when it comes. Yeah. No, you have just
Yeah, I hope.
revised that and then you just had very next day to deal with it.
Mhm.
So good.
Yeah.
Okay. So right then. So the same lady then, Sadia Amelia Wood, 38 years old, had a stillbirth, low risk pregnancy she was. So she was induced and she has delivered last night. And she delivered a healthy 6 pounds male baby. So you know, so that was like last night at 10 o'clock, and this is about, you can say about maybe 11 o'clock in the morning now. So you've been asked by the, you know, the midwife has to come and speak to this woman regarding to discuss the postmortem examination of the baby. Okay. So we give you these 2 minutes.
I'm ready, Dr. Jabin.
You still have 32 seconds, and I would like you to utilize this time. Write down your bullet points, what you want to, which order you will speak.
Okay.
Okay, now you can start.
Okay. Hello, my name is Dr. Fakwani. I'm the doctor covering the labor ward today. Can I confirm your name, please?
Yes, doctor, my name is Amelia Wood.
Okay, thank you. Is it okay if I call you Amelia?
Yes, that's fine, doctor.
Thank you. Amelia, I came to know about the sad incident of your baby dying. I'm really, really sorry.
Yes,
It
doctor.
was really, yeah. I mean, it must have been really shocking, not only for you, but also for the whole team looking after you, for us as well.
Yeah.
So, is your
Yes,
husband
doctor.
a partner with you at the moment?
Yeah, he's I just gone home to get some stuff. Yeah, he will be
Okay.
here. Yeah.
Okay. I just wanted to see him and offer my condolences to him as well. And then maybe, I mean, I needed some chat, which can be quite emotional for you, but it is really important. So do you want me to call him while I speak to you?
He will be probably on the way anyway, doctor. But you can speak. I mean, we have been through so much in the last 2 days. I don't think there can be anything more upsetting than what we have gone through already. So
Yes, you're right.
I'm alright. I'm alright. You can speak what you need to.
Okay. Okay, just before that, are you in pain or anything that I can help you with before I can just sit around and have a chat with you?
No, I don't feel any pain. I mean, I'm absolutely numb anyway. No, no pain at the moment.
And have you named the baby?
Yes, we had given the name of Aaron to him.
Okay, okay. So, Amelia, I wanted to discuss what happened with Aaron this time. Um, you would be wanting to know the cause of it.
Yeah,
Yeah.
obviously, because I was told I'm fine, nothing is serious with me, nothing wrong with the baby or anything. And then suddenly we just lost our baby. So, yeah, of course, obviously, we want to know what went wrong, why we lost our Aaron.
Yeah, and during this pregnancy, you said you were fine, and on the background, you're fit and healthy, no medical condition at all.
No, that wasn't.
Okay, okay. Yeah, I've checked your records as well, and I also did not find anything which could explain to us, and this was quite unexpected.
That's
Yeah.
right.
Now, before everything, I would just let you know that in about 50% of the cases, we don't know the cause. So the basic thing is that we try to find out what caused this, not only to help dealing with the trauma that you had to go through. Like, I mean, as a parent, you would not want to know what was wrong, and also to prevent it if there is any cause that we can prevent for it happening in the next pregnancy. So these are the real things that we want to know about the cause.
Yeah, doctor.
Yeah.
Yeah, they did
So
some tests. They did some blood tests, and they did some, I think, test for infection from the baby's skin as well. So, have you got the results for them?
no, I have not got the result because it's just too early. They take some days to even some weeks in some cases to come back. I know all this time when you are waiting, it is quite worrisome. You feel anxious.
Yeah.
But the persons who are checking, they want to be 100% sure before releasing the results.
Yeah. Okay.
Okay. So has anyone discussed with you about what sort of tests can be offered for the baby?
I know there will. I was told that there can be some examination of the baby as well, and some tests on the baby afterwards. But no, they haven't told me the details about tests or examination they want from the baby.
Okay, I will discuss with you. I will give you the information that you want me to explain in detail as well. Just make sure before even I give you the information that you don't have to go through with all the tests. So we will definitely respect what you wish for. So we have different types of tests. One is where we examine the baby it's a full examination in which we check the baby from outside, from external appearance, if there is anything that is wrong. It also includes getting some samples from the tissue of the baby.
Yeah.
For example, like brain or liver or heart or internal organs, all the complete checks for the baby to go through and to test in further detail.
And how
If
will they do that? Are you guys going to are you gonna cut my baby?
So in this scenario, yes, cuts need to be made, but just be reassured that we deal with quite professionally, with respect, with dignity, and we repair all the cuts. And once the baby is dressed with a hat on, you wouldn't even seeing, so you will not be able to see any cuts externally when the baby is dressed. But yes, cuts need to be made in the full examination.
Oh, that sounds horrible, doctor. That sounds absolutely horrible. No, my baby, I don't want him to suffer anymore. No.
Yeah, I can understand. I can understand. I was telling you because that is the most informative examination. So that is one thing. The other option is where we don't make cuts to the baby. We just take some tissue from the skin, from maybe cartilage or muscles, and small biopsies, like taking small pieces and checking them under the microscope. So it has got limited testing, and then the information can be slightly limited as well. And the third thing is we check.
So these examinations which you're talking about, are they certainly going to tell us what went wrong?
So as I told, unfortunately, in 50% of the cases, we don't even know, even after complete examinations, even after all the testing from yourself and from the baby. So in half of the cases, we don't come up with any cause. There can be. Sorry, did you want to say anything?
No, that's okay, doctor. I don't. It's just my brain can't think anything straight at the moment.
Yeah, it's natural. It's natural. Don't stress yourself. If you want, I mean, the information that I'm giving you, I can again discuss it with you when your partner reaches, and we can go through all the details again in front of your partner. So don't worry about it. I can come back again with the bereavement midwife as well. There are some other tests which involve just imaging of the baby, like X-rays or further imaging, further scans, but they are not very much informative. So we will also offer you testing of the placenta as well as the umbilical cord of the baby. So I mean, starting from the minimal examination, like as less as just the imaging and the external examination, to the complete examination where we check.
What do you mean by imaging, doctor? What is this imaging?
There are some scans, some specialized scans, for example, X-rays and sometimes MRI as well, which is a further specialized scan to give us more information.
Right, okay. I don't know, doctor. I don't know what I want to do. Yeah, I my partner will be here shortly, and yeah, so I will speak to him, and then we'll take things from there.
That's totally fine. That's totally fine. In the meantime, you can just, I mean, I can give you some information leaflets, and I can give you some information about the support groups on the internet where different parents in your situation, they have shared their experiences. If you want to go through that before talking to me again.
That's okay. Your time is over.
It's up to you. Okay, thank you.
Yeah, that's all right. That's okay. Right then. Yeah, that was pretty good. Pretty good. About the, explaining about, and then just particularly reassuring by saying it's okay. If you feel there's no need to be stressed, I can come back and I can speak to you again, and we can explain things. So yes, it's very important, absolutely important, to respond to the patient's emotions. Right, okay, so to start with, yeah, it was fine to start with by saying, Amelia. So again, it's not like when you come in, call from the name Amelia Wood. I'm this doctor and I will be looking after you today. And then just to be, double check, can I take your name and date of birth? And then, yes, first of all, give the condolences to say, so I'm, extremely sorry to know, about your loss. It's been really shocking, and for the whole of the team, all the staff members, everybody really sad, and finding it really difficult to process. And then, yes, ask about her recovery and a grave related well-being, and then her physical well-being will be the next. So then you ask her about saying, so how you've been, dealing with this? How are you processing this? Have you seen the bereavement counselor? Then ask about the partner. How is he dealing with that? And then, yes, you can ask, where is he around? I could see him as well, and and then about their family as well. How's it must be very difficult. It must be very painful for the whole of the family. And then from there, gradually move to the physical well-being. So yes, are you feeling otherwise well in yourself? Any pain anywhere? Did you have any stitches down there? Did you needed any stitches? Are they painful? Have you been able to up and about? Were you able to take some sleep last night? I can't see, obviously, it's in this situation, obviously, it's difficult to be able to sleep, but could you manage to take some sleep? Have you been opening your bladder okay? Your bowels all right? Have you had something to eat and drink this morning? Yeah, those again, very human things, but they are obviously also important because they give you information about our recovery from the delivery process. And then, yes, come to the baby. Have you named the baby? The baby is called Aaron. So from here, you try to, if you can't remember the name, then it's okay. But if you can't actually actively listen the name of the baby, and if you can register, it's good that if you after that refer to the baby by Aaron. But if you are not sure that I can actually absorb that name and remember, then it's okay to say baby. So then you say, so have you named your baby? Aaron, then say, okay, so I hope you would have had a chance to spend some time with Aaron. So then she will tell, okay, I had, and so then you can say, so if you want, we can arrange for you to we can call our trust photographer to come and take some pictures with Aaron, your partner, and any of the family members as well. And then also to take the hand and footprints to have your lifelong memories with Aaron. So that's about the baby. And then you then proceed from there, and then you say, so as Amelia, we all have been trying to understand, to find out what could be the possible reason that we couldn't save Aaron, although apparently there were no problems in the pregnancy or nothing wrong with the Aaron. So here, because we know these bloods and these tests have been done, from your notes and stuff. So you need to say, so as as a part to understand this, we already has taken some bloods from you and from your partner. We have also, sent the afterbirth and also the part of the card for infection testing and also for detailed examination to find out if there was anything wrong there, if there was any problem with the blood flow, the oxygen interrupted to the baby. So we haven't got the results back yet. It can take, a few days, and some of these tests may take even up to a few weeks before we have them back. So we could, do under these circumstances, we do recommend detailed examination of the baby as well. We call it postmortem examination. So do you know anything about postmortem examination, what it involves? So first assess her knowledge, what she says. If she understand already and say, yes, I know in this one you open or you do this, then it's fine. You continue from there. If she appears upset from this examination concept by saying, are you going to cut open my baby? No, I don't want the baby to suffer. I don't use the word of cut for the baby. Even personally, being a mom, I always find it difficult. Grown-up boys know the word even to say they will be cut. You know, it does hurt really, and particularly in these circumstances. So use the word when she says, you know, you did reassure nicely when she said you will cut, and this is well, that will be done in a very professional manner and all that stuff. So I'm not going to say yes, I'm not going to say no to that answer. I will say, in this examination is done by our trained doctors, and you know, they are obviously very sensitive. They understand the sensitivity and the tenderness of this examination, so they will you know, treat Aaron with utmost request and dignity. So in this examination, just like, you know, the other operations, they will open the tummy, the chest, and the head of the baby, and then take some samples of the tissues from lungs, heart, you know, the brain, liver, to send them for detailed examination to find out was there anything wrong with any of these organs. And this can give actually sometimes quite a lot of information for us to understand, you know, what went wrong. And then sometimes, you know, we may come across a condition which can cause problems in the next pregnancy as well. So if we have the knowledge, then we say we can take appropriate measures to prevent that complication happening in your next pregnancy. And this can be helpful actually for some other couples as well who have also lost their babies under these type of circumstances, you know, that this information and, you know, research that does help. So how do you feel about this examination? Use the word postmortem examination because we need to say that. And then if she says okay, or she says, well, no, I can't, and the most likely answer will be, you know, I don't know, or she might say, no, I don't like this examination. Then you can say it's okay, you know, you don't have to. If you don't feel like, then, you know, you don't have to. I won't repeatedly keep saying that the other won't give the limited information. Yes, I will say, but at the same time, I want to make sure that the way I say doesn't make that woman to feel like, if, you know, she might start feeling a little bit of pressure and guilt that if I didn't go for a detailed examination, then we may fail to find the cause and the reason, and then, you know, might blame herself later on that, you know, I didn't do that, and that's why I don't know what happened, or if that happened next pregnancy as well. So obviously that's okay. Yes, this examination can give us a lot of information. However, sometimes even after this detailed examination, we will not be able to find any reason. And if you don't feel to go ahead with that, that's absolutely okay. You know, we could, you know, we could consider then to do a limited examination. We call it limited postmortem. So in that one, what we can do in that examination, we won't need to open the baby's tummy or chest, anything. We can take some x-rays to get information about the bones and stuff, and then some specialized scan. Don't use the word imaging, specialized scans, we call them CT scans and stuff. And they can also give us some, you know, detailed examination about the baby's organs like heart and stuff, and heart and brain, not stuff, sorry, brain and, you know, all these organs. And then with the help of needles, they can take, you know, some sample of the tissue, just like biopsy, and that tissue can be sent for the detailed examination. So, you know, so this can also, you know, give some information. Although, yes, this examination obviously is limited. It's going to give us a bit limited examination as compared to the detailed postmortem. But yes, it's important that you choose what you feel comfortable with, and then don't worry, you know, that is right for you, for your circumstances. So that's how you will explain her the examinations, and then you ask her how you feel about if she has the partner already, then obviously you're there. If not, and most likely, almost always, these stations end up with she says, I'm not sure what I want to do, and and then you need to say that's absolutely okay. There's no rush. You don't need to stress yourself at all. I'm going to leave some written information here about both of these postmortem examinations. You can have a read when you feel, ready to do that. And when your partner is here, and if you would like me to, please let the midwife know. I will come back, and then I can discuss that with both of you again, and then you can take a decision. Obviously, there is a third option as well. If you don't want to have any of these examinations, then you don't have to. Okay, that's absolutely okay as well. It's more important for us that you take the decision which you feel you will be okay with. And then sometimes they ask you the question how long this examination can take. And then the answer is, so, whenever you will be ready for Aaron to have this examination, and you will give us the consent, I will contact immediately that team, and we will arrange that examination done by themselves. It can take, and then we will inform you, how long it can take, sometimes a few days for this examination before they can do this examination. The examination itself doesn't take much long, can take maybe an hour, a couple of hours time really. And after that examination, obviously, we will bring Aaron back to you. And then obviously you can arrange, whatever you want to do to say goodbye to Aaron. So this is how usually the routine conversation takes place in this type of scenario. And I'm absolutely sad after these 2 stations now. Okay, so any quick questions?
Sophia, as regard the partner, this one sample, what sample will be taken from the partner? Blood sample for what? Genetic
Karyotyping.
What?
Karyotyping.
Karyotyping, yeah.
Yeah.
Is that routine for all cases of stillbirth?
Yeah.
Dr. Safia, when the baby is delivered, they are allowed to hold the baby and take the photo. That is a routine there, is it?
Yeah.
Okay.
But instead of saying like you can hold the baby and take the photo, the verb uses has you have the opportunity to spend time with Aaron.
Okay. Sure,
We're
sure.
taking some photos. Would you like us to arrange those photos for you? And we can also take these, for to keep your baby's memories with you. Yeah. Again, instead of making it a technical conversation, keep it a human conversation. Simple. This exam is very easy. Just take your routine conversations, human conversations. Right. Okay. So we've done the 5 stations. We're going to take some break here now. And regarding the rest of the stations, I have lost my basically original presentation. So this particular module, because I don't have many of these delivery module related stations, to be honest. If you guys have some particular stations which you want to discuss, put that on WhatsApp, and after the break we can discuss. Otherwise, I think what I have is maybe we have done postnatal care already. We can do 2 gynae priority lists, because I don't know whether we didn't do that priority list before. Have we done the twin MCMA or MCDA with twin-to-twin syndrome scenario? Have we done that in some antenatal care or somewhere?
Hello, Dr. Sophia. Yes, okay, we did it. We have done this.
Okay. We've done it already, yeah. That's all right then. Yes, if there is anything, just put me out. Otherwise, there will be 2 gynae lists I think we can do. And there was an question in the exam then where this last exam, which is about the 6 weeks postnatal appointment, where this woman I think has late miscarriage, I think, or stillbirth, early stillbirth, something, and she's a cocaine user. and she had, there was a retro placental clot, and then she's found to have antiphospholipid antibodies positive as well. So that will be one station, 2 gynae priority lists. So that will make it 3 stations, and 2 more stations. You guys can tell me about whatever you feel from delivery module. If you think there is something else you would like to do, I don't have much of the stations and delivery, particularly about we've done the instrumental trial of theatre or something.
Dr. B, in May exam this year, there was a station about the cesarean section rate of 39% in a unit, and it was a Viva question.
Yeah.
So if we can do that, that would be useful.
Yeah, we can do that one actually. So that was I was going to do tomorrow, but not tomorrow, in next session, clinical governance. But the clinical governance session become very lengthy and long. There's a quite lot to cover. So we can do actually this one in this as well, unless there are girls have direct some delivery related. Otherwise, we will include this as well. Yeah. Right. Okay.
Also,
So,
asthma in pregnancy. Asthma in pregnancy, like a patient, she's positive, she's UPT positive, and she is a known asthmatic. So that was also there for this last exam.
But that for delivery, like she's in labor delivery, or that was just
No,
like as a maternal medicine?
No, maternal. Yeah, maternal
Was it
medicine.
structured discussion, or it was?
No, it was an SPT. It was a SPT.
Okay. Can you send the details of that scenario then?
I'll try, ma'am.
Because without them, obviously, I won't be able to understand what and which way the station is going, because I haven't had this station. Nobody from people have given me.
Okay.
Otherwise, if you can't remember these things that get us, so everybody else as well, if anybody has the details of this scenario, put them together. So the next one will be clinical governance, and following that will be structured discussion. So all these type of miscellaneous, which we have not done till so far, we will be putting in that one, So this one, if you there is like, otherwise we will do it. So you guys need to be a bit more interactive now and more a bit more proactive. So please bring the stations, suggest the stations. Again, for the structure discussions, I do not have any fixed stations at all. You guys need to tell me what you need to. I mean, structure discussion, there are a lot of structure discussions we already have covered as we go along in the modules. And previously, I mean, I have not been doing structure discussions, but I have just added because people wanted me to do. But then you guys need to then tell what stations you want to discuss or what topics you want to discuss in that one. All right. Otherwise, obviously, there won't be that session if there is nothing to you guys feel you guys need to discuss. Okay, so what are we gonna do then today? Then I have an appointment to attend. So instead of half an hour, we're gonna take break for 1 hour. I apologize for the inconvenience. Would that be okay? Would that be okay, girls, with you?
Okay, Dr.
Yes,
So
Dr. Rabin, that's fine. Thank you.
Thank you. So we're gonna come back to now then. Hello. Right. I'm just quickly looking through the messages. Anything now? Right. Okay. It's absolutely shame to work on this lovely, beautiful day. It's nice and sunny and breeze. Okay. So are you all able to hear me? Someone needs to talk and tell me, please.
Yes, we hear you, Dr. Safia.
All right, great. Thank you. Okay, so who is the next one? Hello, hello, hello. Who's the next one? Come on, please, quickly. Come on, girls, you know the order. Whatever you are doing, swaps between yourselves. I don't know. Okay, so Sadia have posted some stations. Thank you, Sadia. So the one she has posted is you are SPR and delivery suite, and you have been asked to teach a medical student about breech vaginal delivery. These are very standard stations, you know, just going through these steps. But I would say don't worry about these type of teaching stations for this exam, unless, yeah, sorry, Sadia, yes, for you guys, because you are having face-to-face examination here, that there can be something. But the online exam, you shouldn't expect these type of stations coming now where you need. The next one is you can, so you need to breathe, again, that one is that you're going to teach the breath delivery reflection. I think she's just continuing with the same scenario. Okay, is that the only one you have sent us, Satya? About the bridge, okay.
So, Dr. Safia, on online, we didn't know the teaching module they can ask, like, and even drawing when we are explaining, do we need to say, okay, I will draw and you will show?
There won't be, no, because you obviously you do not have the access to paper. You're not supposed to use that, so you need to try to, you know, to say that if you want to explain something, just use your hands, try to make those shapes, you know, with your fingers, with your fist, and just then try to, you know, show them if you want to, but that way. But there won't be any paper access for you to make the drawings or anything like that. And then obviously where you need to have the instruments or dummies to teach something, obviously those not be the part of the exam either. It just doesn't make sense. Obviously they can't just put you to just keep imagining things.
Like breech delivery, forceps delivery, such things.
It shouldn't be there. No, it won't be there. It hasn't been since it has started in all the online exam. It has not appeared any of these stations. Because just simply, obviously, if you can't have the person in front of you, you don't have the dummy, you don't have the forceps with you, how are you going to teach that? Yeah. So just simple, again, just a common sense, really. Right, okay, so we go to the station I left with by saying the 6 weeks postnatal check, where she has been coming after late miscarriage or I don't know, early stillbirth, and she is She is a cocaine user, and there was a retroplacental clot, and there are, I think, antiphospholipid antibodies positive as well. So who is doing this station?
I think it is my turn.
Okay. So that's station for you then, and I start you 2 minutes.
Doctor, please can you repeat scenario once more?
Okay, so this is 28 years old, Emily Hutchinson, and she had a late miscarriage at 22 weeks in her first pregnancy, well, second pregnancy, and she's attending today for 6 weeks postnatal appointment. And you have the reports of placenta and the other test results. They didn't, and that showed that there was a large retroplacental clot, and then antiphospholipid antibodies are positive as well.
Thank you, ma'am.
Okay, that's your first 2 minutes.
Hello, I'm Dr. Anila, one of the doctors in the clinic today. Can I confirm your name and age, please?
Yes, doctor. My name is Emily Hutchinson, and I'm 28 years old.
How can I address you?
You can call me Emily.
Hi, Emily. I'm sorry for what you have gone through, and I've gone through your reports, and you must be aware that you have been sent some blood test and also the fetus for examination. I think today we will discuss about the reports and what best can we do for you in future pregnancies. Is it okay?
Yes, doctor. Yeah.
Amy, how are you and your partner coping up with this situation?
Yeah, I mean, this is something which has happened. Yeah, we're trying to deal with it, but obviously I'm feeling very, you know, bad and guilty about this because I feel I am responsible for the death of my baby. Because I
Amy,
was
please.
told, you know, I have been using this cocaine, and I was told, you know, that this can harm the baby. I tried. I was working on it to stop it, but you see, I lost my baby even before I could stop it completely.
Okay, Amy, did you ever try with the NHS services regarding your cooking of cocaine?
I was on the under the drug addiction services, and but then, you know, this happens. I lost my baby, and then it was absolutely difficult for me to cope with this. So I just started using again, just to get some peace, really.
Amy, do not be upset for what I've gone through. And please do not try to again continue this, because we have, you must be ready for the next pregnancy so that this doesn't happen for you next time. So try to continue with whatever services you are using and whatever you have been doing to quit this, Amy.
Yeah.
If you want, we can give you some support from the counselors who can support you regarding this. You may feel little better to cope up with this situation.
Yeah, thank you, doctor. I mean, I had an appointment to see counselor next week.
Okay. Amy, let me. Is it okay for you if I can ask you a few questions to know more about you, so
Yeah.
that in the end I'll discuss you the reports?
Yes, doctor. Yeah.
Did you resume your periods after the delivery?
Yes, I had one period last week.
Okay. Can you say me more about your previous pregnancies? What was this? Was a second pregnancy? What you have gone through? What
Yeah, the
about
first
the first
one.
one?
The first one was when I was about 19 years, and I had termination then.
Okay. And this did you have any other issues during this pregnancy before this unfortunate event happened? Like
No.
BP, nothing. Okay,
No,
everything was.
my blood pressure was like, you know, it was starting to just creep up a little bit, but it was still in the normal limits. Yeah.
Okay, any bleeding before that in the early weeks of pregnancy?
No, I didn't have bleeding any before, just obviously, other than the time when I just started bleeding and that pain, and then I lost the baby.
Are you following with your GP with any other conditions, medical conditions, Amy?
No.
No. Any history of clots in the leg or in the chest in the family or for you anytime?
I know I don't have any history of blood clots. No, I'm not aware of the family. I mean, I don't see my family much anyway.
Okay. Otherwise,
So
how
I
is the
don't have
support
that
from you?
information.
How is your support from your partner?
Yes, the sport is okay. Obviously. Yeah, he's okay. I mean, he also feels that my cocaine is probably the reason.
Because of this, any problem with your relationship?
No, there aren't any problems. No.
Do you smoke?
I do smoke, yes.
Did you ever try to quit smoking?
Yes, doctor, I was, working on my smoking as well, in pregnancy, but then everything went, wrong, and then I was just finding so difficult to process this all, so I just started same amount of smoking again as well. So I don't know.
Amy, do not be depressed, Amy. As you have known that now the smoking and cocaine can affect your pregnancy. Not only your pregnancy, it can help. It can affect your general health. So try to keep motivated yourself with reducing the smoking and to completely stop it, and also the cocaine use. If you need for support, we are ready to support you at any time.
Okay.
Okay. Coming to your reports, Amy, I have reports of your blood test and also your the other placenta and the baby reports. The blood test, it shows that one antibody called as antiphospholipid antibody is positive for you, which means that it is nothing but an autoimmune condition. That is, normally an immune system should protect your body from infections and other things. But
Okay.
these antibodies, instead of protecting that, they are also acting against your healthy tissues. This
Okay.
also, but thing is, this need to be confirmed again after 12 weeks. That is, after 3 months, we need to repeat this test. And if still they are positive, then we consider it to be positive, and we need to start treatment for that. There is no complete treatment for this, but we can prevent the events like this occurring in the future by using some medications like aspirin and some anticoagulants, like where the blood clotting system will be put at a slow, I mean, the clotting will be decreased little so that the blood flow will be good to the baby in the future.
So do I have that condition because of the cocaine use and smoking as
No,
well?
that has nothing to do with the cocaine, Amy. It is not understood what exactly causes it. It can be because of the genetic factors or environmental factors, or sometimes it may be a short time because of some medication you have used previously, or some infection you have caught in between, some viral infections and all. So that is why sometimes they disappear within a short time. So we need to repeat these tests after 3 months and confirm that you have these antibodies positive. If you have this antibody
So
positive,
what made my baby to die, doctor? It was is that this condition you are telling me, or because the baby died?
Yeah.
Because when the baby was born, they told me that the part of the afterbirth was separated already, and there was some bleeding. And the information I had about about the cocaine and stuff, I was told that the the cocaine use can cause this, like it can separate part of my placenta. So what has caused the death, doctor? Is that like this
You're
bleeding
partly
problem
correct
you're
that
telling me?
yeah, cocaine can cause this. Even this antiphospholipids, what we are talking about, can also cause the same thing, like separation of the placenta at an early stage, or making the baby, not grow properly. All these can happen even with this antiphospholipid antibodies. So now that you know that these two are can be risk factors for you for your next pregnancy, we will try to uh, manage these two. By one thing is trying to cut down the cocaine use. The other one would be to use the recheck these antibodies, and then if needed, we will support you from externally by giving a medication which is needed for you, which will be looked
So
after.
I have killed my baby. That's why then I have killed my baby.
No, don't think like that, because we do not know what exactly has caused it. Even the antiphospholipids can cause the same thing. So you need not blame yourself for this. You were doing a right thing, cutting down the cocaine and smoking for your baby. What you are doing was very good. Please do not get upset with what has happened. Try to motivate yourself and
okay, so we will stop here because the timer is over as well.
Okay, ma'am.
Yeah. So how did you feel, and is there anything you want to add to this?
I think contraception and all also I need to talk because she's now 6 weeks.
Yeah.
And
So
healthy lifestyle.
yeah.
That's
okay.
all.
So yeah, Nilasri, do you have this any further information about this scenario?
I do not have any idea.
No. Anybody, nobody has posted me anything. So anybody is aware of this scenario? How did it appear in the exam? It was just last exam question. From friends or any other group or anybody?
I have the question. Sorry, excuse me. But 2 minutes, I have to find it from mine.
All right.
Just 1 minute.
Okay, good girl. Because it's very important that we have some information what role player was saying, asking, doing, or whatever, because this is how this will go.
You can continue. I take 2 minutes because it's my books. I'm just taking it.
Yeah. Okay.
But I have. Okay, I got it. Sorry, I got it.
Good. Yes, yes.
Okay. It's a recall because you are the SQ5 on call and are asked to assess Mrs. Melanie White, who presented to the emergency department. No, this is the post-operative complication.
Okay.
Have this scenario.
Okay, you have a look then, and we do a little bit of discussion meanwhile. So yeah, so this type of scenario varies, like what I understand we say is if she was using the cocaine and she's a smoker as well, and then she had a late miscarriage, and then now she's coming with, and there is a retroplacental clot, and there is an antiphospholipid antibodies positive as well. The woman is guilty. She feels she's responsible for death. And then she wants to know whether she has caused the death. Was it the cocaine which is responsible for the death of the baby, or what? So it can be quite, this can be quite sensitive station from the communication point of view, how you actually explain things to this woman. We want this woman, we want her to register. Cocaine does have the, this serious risk to cause this clot and separation of the placenta, which can result into death of the baby. And obviously cocaine use and the smoking both together itself also have the issues with the, increase the risk for mother to have, develop high blood pressure, preeclampsia. The use increases the risk of miscarriage, and then they both together as well also contribute towards the reduction of blood flow to the baby as well from the womb. And then this, it can impair the blood flow to the placenta as well, and then it can result into this separation. And then we have antiphospholipid antibodies as well, which obviously at this stage particularly do not have 100% conclusive result for us, but we obviously need to bring that in discussion as well. So
why I say this can be quite, sensitive and difficult station to deal with is because we want her, yes, we want to say as well, yes, these things can be responsible, but we want to say in a way that we don't, cause any more distress and guilt to her that she has done it. So we need to kind of keep her, we need to discuss these things in a way and help her to, start thinking positive, and encourage her to actually go towards she can do, to stop these things before she plans next pregnancy. So yes, contraception is very important. And then our ongoing sport is very important. When we are saying you stop all this, what we are going to do. She said she tried already as well. We need to know what she tried. Did she properly stop there? Was she booked under the drug addiction services? Was were being done? How successful she was to reduce to what amount? And then if she has been gone beyond that one, and what about the partner? Is partner using the drugs as well? Yeah. So yes, was it Umbreen? Umbreen, have you been able to get that or not yet?
I'm Selina.
Selina, sorry. Yes, Selina, have you been able to find
Yeah,
it?
yes, I have found it. Just
Go
I'm.
on then. Yeah.
Okay. The question is, you are an ST5 in Gynae outpatient department, about to meet Kelly Jones, 22 years old, had a 21-week spontaneous miscarriage 12 weeks back. Came today to discuss his blood investigation and postmortem report of the fetus. Blood test showing maternal antiphospholipid antibody. Postmortem report 21-week female. Weight of the child 200 gram. Less than third centile, suggesting of IUGR. Normal fetal anatomy. Placenta normal. Anatomy with retroplacental clot consistent with abruptio placenta. Take focus history. Discuss further management plan. Address our concern.
Okay. So whoever gave you this scenario, did they give you any further information what role player was saying and doing? And
yes, I have made a note. If you want, I can read it loud. I have made it a note.
Yes, please give us, please. Yeah.
Can I interrupt? There was in that investigation, the clot size was 450 grams, and parvovirus IgG was positive. That much I remember. And the role player was very, like, if you said I'm very sorry and all, she was like grumpy the whole time. She was grumpy. How are you coping? So I don't know. I said something, but she was not satisfied and she was sort of withdrawn. So maybe she needed more of support and positive counseling.
Okay, so you have faced that scenario, right? Okay, so Charles, so then when you say she was very grumpy, so yes, grumpy, bit angry, you mean? So what was she saying exactly when you gave the results? What was she saying? Was she guilty that I have done it?
That she did not say like this. I don't remember that, but only the initial thing I remember, like she was not at all happy. Like it's okay, something like that she was saying.
So, well, like what she was not happy about when you were talking about? Can you remember what you were telling? Then she was not happy and she was saying no, it's okay or whatever.
The initial part of the conversation, only I remember she was not satisfied or she was not happy to be like comforted or empathized. Like after that, like a mechanical thing, I went through the investigations and I asked also whether she had any infection with rashes and all, because parvo IgG was given, but that was an old infection. Yeah.
Okay. Right. Okay. Right. Okay. So if we come back to you, Selena, is there anything different or more for
No,
this?
parvovirus I was not given because one of my colleague appeared in this exam in my trust and he missed it. He's a national trainee. He passed the exam, but with questioning later on, it came out that she has cocaine dependence. He couldn't elicit that one. That is the hidden agenda. And the patient was always not very responsive because I think her relationship with her boyfriend has deteriorated because of the baby.
Okay.
So that is the thing, like to find out what was the reason. Like cocaine, they want to find out that reason, but so
okay. So she was asking about the reason, yeah. Okay.
but cocaine was not straightforward given. We have to find it by
I see.
and always being supportive. He was not very much like answering every question very gladly. But parvovirus, I think that's another station. I don't know about that station.
That's okay.
It also came in 2019. So my question is from 2019. Then this time also it came. It's a very favorite college record.
Yeah, okay.
But mainly this antiphospholipid syndrome, we have to tell that we will check your bloods and we will check it again in 12 weeks time. That way we proceed. But I don't know about the parvovirus.
So was she currently still on, like she was again back to cocaine and stuff, yeah?
No, just we have to tell her that if you stop taking cocaine, it will help you and your next pregnancy as well. I think she hasn't stopped that. So we have to just technically tell her, because we can't advise or anything, just to take that the next pregnancy will be okay. So we have very good drug rehabilitation service, so we will also offer that.
Yeah, okay, yeah. Okay, so in that case, anyway, so if they're was not given, obviously we do understand if there is, the miscarriages and particularly the abruption, we suspect abruption as well, then obviously you need to ask about the, in information gathering as well, like whether they were using any drugs at all. And before you ask that question, particularly, again, we don't know what reaction this woman has. We need to be very sensitive to ask that question to say, I have these reports with me now, and then you can give the reports first to say, the placenta, you might have been told, because if there was a retroplacental clot, she would have been informed at that stage as well, that there was the part of the placenta was separated and there was quite a lot of bleeding over there, and then that looks that obviously looks something which caused the death of the baby, because the blood flow and supply of oxygen to the baby was reduced significantly. So you can give the result first. Yeah.
Sorry, they tackle the reason when they told that, have I killed my baby? Then we have to tell that I'm not sure. It may not be the reason for your baby's loss, but those who are on cocaine has similar loss and higher risk of complications. That way we have to just proceed.
We'll come to that in a minute, no, Selena. So right, so this is how you can start up the station if it's clearly not given over there, or she herself doesn't open up and say. So if somebody says, you give the result and she says, I'm obviously giving you all possible scenarios how you can deal with it. So if somebody says like, I am killing, I am responsible, I did then. So before you actually start saying to her, no, you haven't done anything wrong, or this one, you need to first ask why, what makes you to feel so, and what makes you to think like that. Yeah, so first explore the reason then why this person is, because not everybody will say that. Yeah, so that will then bring up then, if there is no cocaine use or anything written over there, then she might come because I'm using this drug and I was told I need to stop, or whatever. I suppose obviously we don't have somebody and she can't remember within the stress of nerves what exactly was she telling. But there obviously are possible ways to tackle the exam. So okay, so that's one thing. If somebody says, first ask them why you think so, and why you are thinking like that. What made you to think this, that you have caused harm to your baby. And then what she says, that's fine, just calmly just listen to them. Again, we're not going to jump straight away and say do not worry and do not think like that. Don't worry. Sometimes yes, we have to counsel and support the women, but that doesn't mean that as soon as they say, we just go so emotions and no, don't think about that and don't worry about. No, first try to understand what that is going on depending on scenario. In this particular scenario, I won't straight away go and say no, don't worry about it. So she says, I killed. Okay, what made you to feel and think like this? Then whatever information she gives me, I was doing this. Okay, all right, okay, I see that. So right, so again, before I give any conclusive or any information to her, I'm going to explore more to say, okay, so right, okay, so how long have you been using this drug? What about your partner? Is he using those drugs as well? And obviously you ask the route of use of the drug as well. How are you using it? What is the level of dependency you have? So when you started this pregnancy, so if she obviously was on the cocaine before she started the pregnancy, was this a planned pregnancy or unplanned pregnancy? So what support and guidance you had then in the beginning? Because obviously if somebody is using drugs and when they embark on the pregnancy, we do have long discussions with them. We explain them about the side effects, risks, and harmful effects of the use of the drug to the mother and to the baby, and also what complications it can make, which obviously can result in greater risk of miscarriages, or even sometimes, depending upon the drug, there can be some risk of abnormalities to the baby, development to the baby structure itself, miscarriage, and the death of the baby even, later in the pregnancy. So then encourage her to tell what she was told about that, was she given? And if she says yes, and then you say, okay, so were you on the plan then? Were you registered under, drug addiction services? Were you attending your appointments regularly? When she says I was trying, okay, so were you attending your resume? So what if you were put on, whatever, was it working for you? Were you, do you think that it was working for you, or you were actually, getting towards where actually you are positive that you will be able to stop this? So I want to have all this information before actually I will start empathizing and counsel her. After all that information, then yes, I need to know, so how you've been dealing, how you've been coping with that. How is your partner coping? And then she says, okay, whatever it is deteriorating, then you can say that, so would you give me some more information that how that relationship is, when you say that it is deteriorating, then you need to ask, so will you explain like in what sense is deteriorating? Does it get to the stage of argument? Does it make him to become violent, or does it make you to be so angry to become violent? Yeah, safety is important here as well, because people who are using drugs, you need to then, make, it's not only that they can be subjected by the partner, they might themselves become aggressive and violent as well. So these are very important questions to ask. And then you can proceed from there and say, so if she is like, she says, yes, we have been, and she's just more grieve rather than being chaotic behavior, then obviously you can start then, going in that way to say, what support you have and the counseling. Have you attended any sessions? Would you like us to arrange? How you feel about if we arrange some bereavement counseling for you and your partner? If they are struggling on this one, both of them together and partner is blaming, you say, so how you feel if we actually make a combined appointment for both of you, so your partner is here as well, and we can discuss these things, so that he's also clear and understand that there could be other possible reasons as well for this miscarriage. And once he's in position to understand the things, he might, not feel that bad, because it's not only that we want to save her, we don't want the relationship to be broken either. So we need to then ask that way, like offer, shall we see you both together so we can explain you these things? And then you go further, and then you explain the results have begun. You say, so what happens with the, as you said, you were informed about this as well, so this drug abuse can be could be the reason, one of the reasons. However, we did some blood tests as well to find out, other possible, because sometimes the women can have some bleeding or clotting disorders, in which their blood start making some clots, and as a result, that can actually obstruct the blood flow to the afterbirth and to the baby, and that may also result in separation of the afterbirth and cause some bleeding and cut off the blood flow and the oxygen supply to the baby. So when we did these tests, one of these tests has come back as which shows that this could be possible as well. We call it antiphospholipid antibodies, and then you can say, like, it's a bit kind of, it's not something which you can control, or you have got is as a condition, is something which is passed on to different family members. It can be, and it is some condition where you can say, we call it autoimmune. This is a condition actually where, kind of in simple words, your body's protection or immune system is kind of working against yourself, because obviously normally our blood should not clot, because the baby needs blood and all that stuff. But the people who have these type of certain these abnormal condition, they can make these clots. However, the result of this particular test is not quite valid, and it's not conclusive, because the stage when it was done obviously is done immediately after the delivery. Now, after the miscarriage, pregnancy itself is a state in which blood becomes more thicker than usual, and there can be certain changes in the blood clotting and bleeding factors and elements and everything as well. So we need to repeat that blood test again. All right, so you give that time, 3 months or whatever. We will repeat that again after this much time from your miscarriage. And if it still came back as showing the presence of those antibodies, then that means that you have that condition. So which can actually, so there may be possible. Now, when she says, have I killed the baby? Was it my cocaine? It's absolutely difficult for us to answer. Because both of these conditions, we know if your repeat test come back and shows, yes, you still have these antibodies and you carry that condition, which we call antiphospholipid syndrome, that can also behave exactly the same way. It can affect the blood flow, it can make the clot, it can make separation, and it can bleed. And the cocaine and the smoking, they can behave exactly the same way as well. So it's really difficult for us to tell you what that is. However, we will strongly encourage you to, stay positive. And if she, when she was telling that she was trying and she was attending her appointments regularly and stuff, and she was doing that, then I will encourage her. And I will say, the good thing is I must appreciate you that you actually was trying, you were making positive effort by attending your appointments, and then, to try to quit that all for the benefit of your baby. Okay, so I would encourage you not to feel that guilty that you are responsible, you kill, because you are actually on the way to stop it. And if she says, and then I started again because it's very common, because she's depressed and all that stuff, and they find it easier way escape. And then I will first acknowledge by saying, yes, I can understand, obviously, having that, sudden shocking situation to go through, and particularly all the other circumstances around you as well, when your partner, your relationship is in a quite difficult situation as well. It's not unusual to just go, revert back to the drugs and all that stuff. However, if you started once and you were able to make a progress in that means you can do it. Yeah, you can again start working on it. So you can, what we can do, we can arrange your appointment again with your addiction services. We can also arrange your, support in the form of counseling as well, so that you can start the quit program. And I will suggest you to, start some contraception, which I can discuss with you at the end of this consultation, so that you actually can, work on the your drug use and also on the smoking. And slowly and gradually you cut it down. As those services will help you to do that. We can also arrange your appointment in the smoking cessation services as well. Try to, have a healthy lifestyle, exercise, bed hydration, try to have some, and then reassure as well that we understand these both things are not something which you can just, decide and then you can leave them straight away. It will take time. However, as long as you continue your effort and you cooperate and you attend your appointments, you will be able to do that. Many women have done it. Right, so and that should then help you. So if you have quit completely, your next pregnancy hopefully will be healthy and you will have healthier outcome. Now coming back to that conditions you have, AP, antiphospholipid syndrome, we will do that test, repeat test that after so many weeks, and if it still is positive, and then that is something we also then need to, look after in the next pregnancy. So with that condition particularly, then it will also become equally important that your next pregnancy should be planned pregnancy. So some effective long-term contraceptive method at this stage is very important till you are ready to get pregnant. And then as soon as you become pregnant, you will need to make appointments so that we can start you on some medicines we can give you, start you. You don't need to go into the details of the medicine, but then we will start you on some blood thinning medication, by doing the other assessment as well to assess your risk, any other risk factors present as well. And then we will start you on those one as right from the beginning of the pregnancy as well. We'll keep more close monitoring on you. And then hopefully next time we will be able to, by mutual attempt and effort, we will be able to have a healthy pregnancy and healthy pregnancy outcome. How you feel about it? Yeah, give her, just say, so are you happy for me to arrange this appointment for you? So that, yeah, so these are the possible things you can touch in this scenario. Yeah, I don't think there should be something more complicated than that. Happy? Hello, ladies, are you all there?
Yes, ma'am.
Yes.
Okay.
Yeah, please.
Yeah.
Shall we ask her some questions to discover if she is having some psychosis or anything related to the difficult event? Means if she wants to harm herself or anything like that.
Okay, so psychosis is an entirely different thing. Psychosis is not something which people can develop like just because they have gone through some difficult circumstances. Psychosis, if we say, is a long-term condition. There are different various reasons. So I won't be worried about psychosis point of view, but yes, we did the support and counseling if she's feeling quite low in mood at this stage. So when we ask her how you coping with this, dealing with this grief and situation, and then we talk about the relationship as well and say, if that is deteriorating, how you're coping with that and how you feel about attending any counseling. So the counseling, yes, that will be addressed, but I wouldn't use the word psychosis or any mental health issues here from that point of view. Grief
Okay,
itself
thank
is not a situation which increases the risk of depression, the depression and the, well, depression can be, but not psychosis. All right. Okay, next, please.
you. Thank you.
Do we have to explore more of a social history, occupation, sports, or the later? So we don't need to worry about the occupation. There is too much to talk in this, It's not only about the cocaine use counseling. If that was the only situation, then yes, we can go in detail. We have to talk about antiphospholipid syndrome. We have to talk about this one. We have to also establish how she's coping. So I wouldn't go into those details. All I need to know is how long she's been using these drugs. Is there any other drug she's using, particularly through needles? About the partner. And about to know what she has done about in the pregnancy. That will be. I won't worry about the occupations and stuff. And the sport, obviously, we have talked already by asking, and when we have encouraged her to say that if you're happy to incorporate, we can make all those arrangements. So we will involve the GP. If it comes as a structured discussion, then yes, you will have the addiction services environment, you will have the GP, and then even we will assess any safety risk or anything else if she needs any sport worker, social services support worker as well. Okay, we need to go to the next station now. Next person, please. Hello, hello. Who is next, please, quickly?
Is it Neelam now? Is it Anilasri who has done now?
Anilasri has done, yeah.
Okay. Then next should be Neelam.
Hello, Neelam, are you
Neelam
there?
is... Then Reena Kumari.
Reena Kumari? Hello? Last call for you, Reena Kumari. Are you with us? Okay.
Selena.
Selena. Yes, Selena certainly is with us. Yes, Selena?
Yes.
Yeah. Right, this is for you.
Ma'am, I think we did this case, ma'am.
Have we done this already?
Yes, ma'am. In the starting gynec modules time, I think we did.
Oh, no, okay, that's fine then. We have done these lists, okay? What else then? Where are we going from here now then to give me stations?
Is this the station?
No. She said we have done the gynae prioritization list already, so obviously we
No,
don't need to go into that.
we haven't done in this course by me. I think maybe the previous course.
Okay.
We haven't done, ma'am. Madam, we haven't done.
We haven't
All
done.
right. Okay. Okay. So who was spreading this misinformation then? Sorry.
Ma'am, I never had the previous one, ma'am. Not this. The previous one we did. The previous slide you have put. Infertility
Okay,
and
right.
this.
Okay. Is this one? Okay, girls,
This
just
one
it's fine. Let's do one of these anyway. Let's do this, yeah. 2 minutes starts, Selena, now.
I have forgotten how to do it, but I'll try.
Don't worry.
Is this only 3 cases? Is there any other slide?
There isn't any, but I can add one more case. So the other one is 28 years old for a section evacuation from older pregnancy, and her BMI is within normal range, like 23. That's your 4th case.
So should I start the first one?
Yeah, your first 2 minutes gone, yeah. Yes, can you start?
Okay. The first case is a postmenopausal ovarian cyst. So she is 62 years old. So first I have to do a risk malignancy index, that is RMI. So her CA125 is within normal range, 18, and then as she is postmenopausal, we will divide it by 2. So her RMI is 36. So it's a normal, within normal range. So we can do it in the gynae OT. But as she has postmenopausal, first I have to take a brief history whether she has any other comorbidities like diabetes, hypertension, and then whether she has got any other surgery before, and how many children she has, if she hasn't to anything, and then whether I'll check whether her consent has been taken and risk has been discussed, and then I will check that whether the patient has been counseled that though she has got a simple ovarian cyst, because she is postmenopausal, our aim is will be removal both of the ovaries and tube, though it's a simple ovarian cyst. So that is the thing is coming to my mind regarding this patient.
Okay, so so when you were discussing this list, tomorrow list, that's fine, but I'll just give you some more information about. So you need to talk about how will you prioritize these cases, in which order you will operate them, and you need to discuss any possible complications and what you will do to prevent them from happening. Okay.
Okay, because it is a simple ovarian cyst, we are doing laparoscopy, so it will be a day case. So I think I aim to do it early so that she can go home in the later part of the day. So our bed will not occupy. So I'll prioritize it early, and because she is normal BMI, so I will discuss with her about the during consent. I think it's already been discussed, but still I will discuss with her about like pain, bleeding, infection, and injury to the surrounding organ. And also I will make her aware that there might be some shoulder tip pain because of the gas, and then I will explain that there is chance of clot in the leg and lung, so that we will give her some Flotron. And because she is a day case, so we are not going to give her any thromboprophylaxis at home, and she is not a cancer case, so that is the thing is coming to my mind to discuss with her. And definitely I'll also ask about her medical disease and previous surgery, because then our route of entry will be changed if she has a previous history of cesarean section, like this thing is coming. And then as we are removing both of the ovaries, and she's 62 years old, so I will not discuss, I think, HRT with her, because she is by now menopausal. So these things are coming into my mind.
Okay, so you need to keep going to your stations.
The second is 32 years old, hysteroscopic resection for submucous fibroid, 5 centimeter in size. Okay, so she is a nulliparous woman who is going for a hysteroscopic resection for her fibroid. So I will take a small history that I gathered that she is nulliparous, that she has never been pregnant. I will ask her fertility wishes, because she is 32 years old, but already she had an endometrial ablation. We usually do not do this in nulliparous who has no children. So I will try to explore a little bit why endometrial ablation was chosen, because she is nulliparous, whether she has got no wish for having a children. Her recent hemoglobin is 9.5, so I'll make sure that group and save has been done. So if she needs blood, it can be given. And I will also discuss with her complication, because we are going for hysteroscopic resection. I will just explain the procedure to her, that it's a camera examination of her womb, and we will try to remove the fibroid from her wall of the uterus, and it might resolve her symptoms. But there's a chance of complication like perforation of her uterus, injuring to the surrounding organ, and it's quite straightforward. And if we find any abnormal tissue or anything, we will take a biopsy to have a look under microscope. So that is the thing is coming into my mind regarding this patient. And then I will tell that she might need further treatment if it does not help her relieving her symptoms. And the third one is 42-year-old para 4 for laparoscopic total hysterectomy for menorrhagia, BMI 30. So I will take a history that whether she has got any other what other treatment she has received for her menorrhagia, and was anything diagnosed as a reason of her menorrhagia. And she is para 4, whether she is made up her mind that she doesn't want any children, or she want to remove her womb. In this country, even without children, they want to keep their uterus. Then I will discuss with her that we will just remove her uterus, so she will not need HRT. Then I will also take a history whether she has any medical disease, any previous surgery, and how her babies were born, and any allergy. And also I will discuss the complication of the laparoscopy, and also if any injury happened, we might have to do a laparotomy also. So this is and also I will talk about her thromboprophylaxis, because she will remain at least 1 or 2 days, at least 1 day overnight, because she is having a major laparoscopic procedure. So that is coming into my mind.
The fourth one?
And then fourth one is a 28-week suction evacuation molar pregnancy. So first I will confirm that her history, that her ultrasound scan, it is complete or partial mole. Then when was her LMP, and whether blood grouping and screening has been done, and it should definitely be done by a senior person or under the supervision of the senior, because there is high chance of perforation. And then I will check what is her beta HCG baseline, and then I will make sure that we don't use any oxytocin. Only prior to the procedure we might use some misoprostol, but that is also just before the procedure. And also usually we do not use the oxytocin routinely unless she is bleeding profusely. And the two things come into my mind, it should be done by a senior person, and also the blood should be ready, and the pregnancy, the tissue will be sent definitely to the histopathology for confirmation of the diagnosis. And then we have to counsel the patient that what the molar pregnancy is. I think by now the patient knows that. And then I will check her consent has been taken. And also, if injury happens sometime, we might have even go for hysterectomy, but I haven't seen it here. So these things are coming into my mind. Sorry.
So what's your prioritization order?
Okay, so prioritization will be, I will do the 62 years old, so she can go home. No, I will do the suction evacuation first, and then 62-year-old, because that's the day case, and then I can do the laparoscopic total hysterectomy, and then no, I will do the first two one first, because those are day case, so they will go home. Otherwise, the bed will be occupied. And then if the suction evacuation is bleeding heavily, then we have to do that first, and then the 2-day case, and then the one who might need a bed for overnight.
Okay.
The laparoscopic total hysterectomy.
Okay, that's fine. Thank you. So I'm having my lunch as well at the same time, so I apologize if it sounds like I'm eating in the background. Because I couldn't have that during the background. They were in the break time. There was a few things to thought out. Right. Okay. Thank you, Selena. That was pretty good. The order of prioritization, yes, that was fine. This is how it should be done. Usually, the evacuations, they are done the first one, and then you go for diagnostic laparoscopies, and then you go for those therapeutic or operative laparoscopies, and then major procedure. And then yes, the reason behind is the short cases to be done early, so they can be sent home by the end of the day. And then particularly the other reason is because if they're having small procedures being done, then for suction, and that somebody being anxious, why to keep them waiting so long? Just do them out of the list quickly. But it's fine. Again, this is usually the routine which is being followed. But even if you have said you want to do some longer, as long as you can justify why, maybe you can say I need help. Maybe in this one gets complex, so I want to this. But I will then make sure in that case that the other patients who are short procedures, if they are going to be later, to start their nil by mouth accordingly later. But instead of complicating things, better to do the shorter procedures first to start with. And then the second thing is this conversation is very clinical conversation you are having with your consultant. So the language needs to be clinical. We do not make any preconceptions or give any views. Just like as you said, in this country, the women, even if they like to keep their uterus. No, there's no need to give this statement at all. We don't need to. Let's talk about the facts. Yeah, when it's a clinical conversation, and even with the patient as well, we need to talk about the facts and the evidence on the clinical. We don't need to give these social type of comments on things. So right, okay, so yes, the first one. So how we basically speak about these. So when you are doing this, there are three things. This is not the time now basically to take the history and do that. This is not, that has been done, that's documented into the notes. Now your consultant, you both are going to operate this list tomorrow. And she just want to be, and obviously every surgeon, as a, you do, I mean, as ST5 training, maybe you're in busy rota, you may not have the time, but the consultant will look on tomorrow's list a day before to see what I got. They will go down and see the patient speak, just that quick around to make sure they still want to go ahead with the patient. And just to know as well, is there anything we need to have in place, thinking about possible complications, and then do we need to keep some measures in place then to prevent those, or if you need any extra help, maybe some interventional radiologist or anything like that. That's the reason to see this list a day before. So, and then what we are trying to look into, yes, possible complications. Are there any risk factor, any possible complications, what they can happen? And if they happen, how are we going to manage it? And if you think in the management of those complications, we may need to perform some extra procedures. Has this patient been consented for those extra procedures? Yeah, these are the few last minute things, obviously, you would like to double check and make sure. When you talk about to look into these ones, then there are again 3 points you can think. Number one, think about what are the complications or risk factors of this particular condition I need to take into account, which can go wrong. Second is any risks and the complications of the procedure and the route of the procedure itself. Is there anything which can actually contribute from this particular, any factor which can make this particular route, like laparoscopic procedure, more difficult, or I'm assuming any extra risk I need to be prepared for. And the third one is background risk factors she has. If she has diabetes, if she has a higher BMI, if she has heart disease or anything like that. What are the other background, risks which can make some issues, and I need to keep in mind. Like these women, the second woman, hysteroscopy resection, BMI 32. This woman, we know in hysteroscopy resection there can be a risk of hemorrhage, and there's a risk of perforation. And if perforation happens, then we may need to proceed to the laparoscopic. And if she's bleeding quite heavily, yes, the chance is small, but then we may need to even convert this procedure into laparotomy. So if we convert this procedure into the laparotomy with BMI 32, this woman is going to be duration of surgery is going to increase, the post-op duration of stay is going to increase. This woman will be high risk for VTE. So then that means we need to be aware and consider that as well. Yeah. So regarding the procedure, then we said these can be the complication, perforation and hemorrhage. Has she been consented? If she has this, then we may need to proceed to laparoscopy and laparotomy. So I need to check that consent form as well. Is she aware of that? Yeah. And because of the 32 BMI, well, that's hysteroscopic. We see the laparoscopic procedures. If there is a high BMI, we need to be aware. So say, for example, we're talking about patient 3 now, 42 years old, para 4, laparoscopic total hysterectomy for menorrhagia, and BMI 32. So in this one again, high BMI. So first one you think about, okay, what can be the complications or problem we can have tomorrow because of the background risk, okay? So the BMI is 30. Is there any other risk factor like she's hypertensive or diabetic or anything like that, okay? So for with the BMI, laparoscopic procedure can have its own risks of, the risk of the, at the time of entry. We may not have the appropriate entry. There is a slight increased risk of having injury to viscera and to the blood vessels. And then it's very important, obviously, to look at, does she have any previous history of any surgery? So we can think about the adhesions. Are they going to complicate this procedure? So that's about a bit of background which we need to know, which can contribute towards our procedure tomorrow. Laparoscopic total hysterectomy for menorrhagia. I need to look into the scan. What is the size of the uterus? Is there some fibroid or some reason for the hysterectomy, or what was the reason, right? And if it's a bulky uterus, a large size uterus with the fibroid, then we may not be able to complete it by laparoscopic route. So we may then end up doing the laparotomy as well. And for hysterectomy, again, whether it is because of fibroid or not, obviously there is a risk of hemorrhage, heavy bleeding, or due to the injury to the viscera. Obviously, for all laparoscopic procedures, we do consent them for laparotomy as well. So that is obviously next thing you need to check about. And if she has a menorrhagia, just a common sense, what is her current hemoglobin? Yeah. And have you taken the consent for blood transfusion? If we say so, you just simply need to think about the procedure, and then in the procedure think about what we will be consenting this woman. Consents have been taken by now. You just need to go and check that consent and just make sure she's still happy to go ahead. You just need to keep those things in your mind on the consent which you write down. Has she been consented for blood transfusion? Does she have any objections for the blood? I will be just checking through the consent form of these as well. Yeah. And if she's what are previous last HD. The first lady, 62 years old, laparoscopic cystectomy for 6 centimeters, simple cyst and CA125 BMI, this one. Again, you need to just simply say any other background, like does she have any other medical condition which could, put her any risk of complications. Simple, you need to know that. Then all you need to say about review her notes to find out if there is any other, background medical condition or any risk factor. And then CA125 is one to find a simple C. So you say, okay, so the malignancy risk index calculation is low. It's not a high risk for malignancy. However, in a post-menopausal woman of age of 62, the recommended according to the guideline is to go for bilateral, salpingo-oophorectomy. So why this woman has been, listed only for the simple ovarian cystectomy? Yeah. So there is so I will need to explore with my consultant and also review the notes what the reason is. Has she had that the ovary has been taken already? Yeah, or what? Yeah. So this is something important again as well for us to see what is there, like why she's having this and why not a standard treatment. So this is how you talk about this particular woman. The suction evacuation, yes, it's a simple one. So, suction evacuation for the molar. Again, you need to, check the consent to make sure, and obviously before you operate tomorrow, you will check with the woman if she's still happy to go ahead with this one. And because there is obviously the molar pregnancies, there's a high risk of bleeding during that time. I wouldn't say it should be done by a trained person or seasoned person. That one is just for some time for you to understand things. Again, here you need to clearly say who is that and who is going to decide who is that trained person. That is, we know the molar say it should be done either by the consultants or consultants present in theatre. All right, so you can say that I'm aware the molar pregnancy, the risk of perforation is quite high, so it will be done by the consultant, or the consultant will be present in theatre, and she's the molar pregnancy because of the perforation as well, and because of the condition, they're high risk of having hemorrhage. So I will just check from the the notes and with the women as well that she has been, her blood group has been checked. What was her last BMI? Is she bleeding at the moment? And then plus that she's okay. If she bleed heavily, then we can give her blood transfusion. And then yes, a little bit plan you can give. The time is still there that if she goes in hemorrhage, then we will immediately try to complete the suction evacuation and then give her syntocenon and then start on the syntocenon infusion. However, if the bleeding goes uncontrollable, then we can't give syntocenon earlier as well. But obviously the consultant will be around, so I will consult the consultant. So this is you do. So as a rule of thumb, as I said, like these 3 points, keep in mind any complications or put this woman in particular high risk tomorrow because of the background risk, usually BMI and any other health condition, and then try to see their hemoglobin is low or what's going on, just like this hysteroscopic resection woman, she has a HP of 9.5 just already, and we're talking about hemorrhage. Yeah? So all the women in reproductive age, we need to exclude the risk of pregnancy as well. And there are 2 ways to do that. You will say she on some regular contraception, and then just that contraception needs to be stopped if it was a long surgery. And is there any, all you need to say is, I need to exclude the risk of any later pregnancy by asking the woman if she's a contraception or is there any risk of pregnancy, basically she has any unprotected sex. And they all have pregnancy test done. Okay.
So, ma'am, priority, like which case you will take first and why?
Okay, so we just said that. Selena clearly explained that one as well nicely. The priority-wise, you do evacuations first, just because they are simple, shorter procedures, and the women, obviously, who are miscarrying or any complication, they're very anxious as well. There is a bit of feeling of loss and grief as well, not only the stress of surgery. So they usually are done in the beginning of the list. And also they can be sent home later on after observation. Then you do diagnostic laparoscopies. Yeah, the shorter procedures first, so we can send them home by the evening, and then the major procedure at the end. They usually is very typical list of 4 basically cases, very typical UK consultants list, because it's only from like 9 to 1 or 1:30 kind of list. In the afternoon they have something else or some other list. So they usually have this very typical pattern as well. Maybe 1 evacuation, otherwise maybe just these 3 patients. 1 may be kind of some diagnostic or 2 of these type of short procedures, and then 1 major case. Right. Next.
Dr. Safia, that hysteroscope they have given endometrial ablation was tried. So entry also might be difficult. What is the point from that? And size?
Yeah. So when you talk about the risk of the procedure, well, I didn't go into that detail. Yes, good. I should go actually tell you that as well. So going back there, then where was that list? I think here it is. No, that's not the one. Yeah, so when we talk about the hysteroscopic procedure, obviously, yes, there can be risk if she has that endometrial. You will just, all those risk factors you'll be thinking about. There can be difficulty in entry, there can be adhesions, which further increase the risk of perforation. So you need to say that she has been consulted and that consent has been taken. But if she's still bleeding heavily with endometrial ablation, I wouldn't expect a lot of adhesions and stuff there, because that simply means her endometrial line is still intact and is proliferating every month again.
Okay. And the size
No,
of the
thinking about Selena, you said like she's nulliparous, why she has the endometrial ablation. So that's fine. I like you at that point. But at this stage, I won't be worried about why she's nulliparous. That conversation all has taken place already. I'm not bothered now to go and speak to her about have this been discussed. That thing like why you had this and why not, and has she been discussed about the alternative options? That homework has been done in outpatient clinic in couple of appointments already. When she was consented, even then that discussion has taken place. This one is just brief discussion with your consultant to be ready for tomorrow's list. Okay, this is not management. We're not asking about the management of these patients.
Sure.
Okay, so the next person.
Sorry, Dr. Safia.
Can I do now?
Yeah.
Dr. Safia, in this station, what are they testing? Our knowledge about what? About the consent or about how to, what are we exploring? What do you want us to know from this station?
So yeah, so they want to know, or as I said as well, you got this list tomorrow. You have the discussion with the consultant. You need to discuss what possible complications or situation you can come across tomorrow, and what are you going to do pre-hand planning to prevent those complications from happening, or your plan for the situations you will come across. All right, so let's do one more of this list, and I hope that we will be able to even be more clear. Where is the other list gone? Okay, that's one. So this is for you, Pramila.
Ma'am, this one we did in the gynec, I think. Isn't it? What others feel?
Yeah.
This final
Yes.
adhesions, what to do and all.
Yes. Yes, we have done.
It's okay. I can do it once more. It's okay to do. Is this the scenario?
Yeah, so so your junior has done these two referrals to MDT. So this is what she has written. So you need to talk and teach this junior basically how to do the MDT referral, what you include. And is that okay, Pramila?
Okay. I can try, ma'am.
Okay, there's your 5 minutes.
Can I know the name of this junior?
So she is Ellison Taylor.
Okay. Hello, Alison. I'm Dr. Premila, your ST5. And
yes,
have you joined? Yeah. Have you joined here recently?
Yes, so Pramila, I'm here like it's been about 2 months now.
Okay. So
and, you know, this gynae ops is so busy, you know, all the time. I can't get my head around about things. So
yeah.
I sent these to the secretary asked me to complete this MD referral thing. So I send it off, but it wasn't quite right way done. So basically then she asked me to come down and discuss with you how it should really be done.
Okay. Okay, Alison, that's good. Don't worry, it's always busy here. As time goes on, we will get adjusted to this pace. And as we learn along, these things becomes much more easier. And writing a letter to MDT is going to be a little tricky. That you have to convey everything you know to them, but in a very precise way, you have to inform them. That letter should be conveying whatever you want to talk with them. So, do you know what this MDT is?
Yeah, so that's multidisciplinary team referral. Yeah.
So each multidisciplinary team will have different type of people in it, including the different specialty people. So including the radiologist and the pathologist So everyone will have their own opinion to put in. So only if we give the current status of the patient, all the relevant investigation findings to them, they will be able to get a collectively, they will be able to tell us a opinion. Okay, so when you are writing, it should be very crisp, but it should be very precise. Everything should be there, and there is actually a standard pro forma to do that. So you can actually start by writing the patient's name, her complete name, the date of birth, age, and her NHS number. Everything has to be written properly. And then here in this first patient, you have written there is a unilateral 10 centimeter multilocular cyst, and so it doesn't convey to the MDT about the remaining other background risk of the patient. So you have to tell about what is her, because the parity matters a lot when the MDT has to make a decision. So you have to give in short form what is her parity like, whether she's having any pre-existing diseases, and what complaint she came to us with, and what was our examination finding. That is also very important. And also regarding a short summary of the sonological findings which we have got, including if MRI, if it has been or anything has been done, that also has to be included. Is it clear?
Yes, doctor. Yeah, that makes sense. Yeah.
Okay, and also you have to give the record of the already pre-existing conditions, like what is her BMI like, what is her past histories like, whether she has got any long-standing diseases, whether she's on any medication, any significant past or family history like malignancies in the family, because that again can change the course of management. So those points also should be written properly. So in this patient, we will have to add actually what she came with, and what was our examination findings, and more details about the cyst, and the scan findings, what has been found out, and any significant past or family history also has to be added. And then we have to also communicate to the MDT that what we actually want from them.
Okay, Pramila. Yeah, I mean, I understand that's important to tell them, but I mean, there's a small short form. There wasn't much space to write it down. And I mean, the patient notes were going with her anyway. And I thought, I mean, the scan report and histology report, everything is there. I mean, they can look there.
Yeah, it is there, but the problem is they are meeting for, they are all very busy people. They are all coming together and they will have number of cases to discuss on that particular day. So if we can give all the relevant findings in this short summary, it will be actually useful for them. And many times when they go through the case notes, a lot of people are sitting together, so it might be difficult for them to go through the case notes properly. So we know the patient. We are the ones who can actually tell them what is the current status in a nutshell. So that will make their job also very easier, and it will be made more productive also. So, and also you have to also write to them what you are expecting from them also. What advice you want to get from them, like whether it is about the diagnosis part, whether you are going to ahead with what further investigation should be done, or whether we should be what surgery we have to plan. So all those what we actually expect from them also has to be communicated. Okay. Is that clear?
Yeah. That makes sense.
And the second patient again, you have written 70-year-old, she is postmenopausal, and you have written that it needs fast track referral. So fast track, you know what about this fast track referral? What is it?
That's like about in cancers, malignancies, stuff we need to make a referral within 2 weeks.
Yeah, that's good. That's very good. So we have to make sure this is being done within 2 weeks. So we have to tell the MDT that this is a priority one, and this has to be seen in that 2 weeks. And again, you have to write the background risk, any family history. She's a postmenopausal bleeding 70-year-old. So we are, in our mind, we are suspecting, already we have done the endometrial biopsy and we have got the report as adenocarcinoma. So she might be having hypertension, diabetes, her BMI might be high. Is there any history like that?
I will have to look into the notes. I don't remember by, now. So,
Okay.
yeah.
That's okay. Just go through the notes once again and try to find out these relevant points so that you can put it everything together. And what is the confusion regarding further management, whether regarding the surgery part, what are we worried about? Because usually when it is a endometrial adenocarcinoma, we go ahead with the staging laparotomy. So as far as an MDT is concerned, other than this, what other extra decision they have to make? Whether we are asking them regarding further investigations like MRI, whether it is needed, and again in this case also that format you have to follow. Like you have to give them the nutshell in a summary. The HPR report has to be properly written. About the grade, you have only written that it is an adenocarcinoma. So they will want to know about the grade of the disease also, but because that again changes the management, surgery, and the post-operative, whether radiotherapy will be needed. So that also you have to include, and all the radiological findings, specific findings. Okay, is that okay?
Yeah. It's more
okay.
clear
So
to me now,
yeah. So what you can do is you can just go through this once again and try to rewrite this, and I will again go through that before you send it, and we together can modify it and make it better and more productive. Do you have any further queries?
No, that's fine. I write it down then, and then I'll just show you.
So don't get worried. These things happen. Everyone goes through this process. If you have got any further doubt, don't hesitate to contact.
Yeah, that's okay. Thank you.
Okay.
Yeah, thanks for your support.
Thank you.
Right, good. That's good. So
was this the one that's needed? I was not sure.
Yes. Yeah.
Okay, thank you.
So, right then. Yeah, so it is in that clinical governance recording. Okay, so yeah, so first we need to yes, if the name is given, which will be given obviously, that's your junior. Don't go and just straight forward call them by their name. You in this particular, you don't need to even confirm the name. Yeah, it's not patient, it's your colleague, and you know them even they are there for 2 months or even for 1 month, unless they have just started yesterday, and obviously if they have started last week, they won't be doing the MDT referral straight away anyway. So you're supposed to know your team. You're supposed to know your juniors with you. So whatever her name is, Emily, Amelia, whatever, I will just call the name straight away. Hi, Amelia, Pramila. So just a social talk, routine start we do with our colleagues. How you been doing? How you settling in the unit? How long you been here now by now? And how are you finding everything? Do you feel it's supportive? Everything? Any problems you having? At all? So she said like, yeah, but the gynae ops is, but it's like it's so busy all the time, and whatever. So just ask them, even if we think it's just a routine thing she's saying, it's so busy here and there. But when somebody is saying sometime we don't know, there might be something they want to discuss with us. So you need to ask them, okay, yeah, that's right. Yes, ops gynae is really, acute, and you have to be unfit all the time. But is there anything particularly, other than being obviously busy? Anything else particularly you're finding difficult or you're concerned about? Yeah, so give her that chance as well, if there is anything she wants to talk. And then, you can say, okay, so we had this, a bit of this teaching session arranged. So I understand you wanted to discuss how to write this MDT referral. Is that right? So then obviously she will start with something telling, okay, I did these referrals and the consultant said this, blah, blah, blah. If she has already told you this one is, then it's fine. Otherwise, check her expectations and just say, okay, so, right, so understand we are here to discuss about how we make MDT referrals. So would you just like to tell me what are your, specific expectations from this session today? So just assess that first, what she says. So if she says, yes, this one is this was saying, then you say, okay, then start is fine to reassure them and say, that's okay, don't worry about it. Obviously, you're still quite new in your training. So by all means, I will be happy to basically teach you about how we do MDT referrals. And then what I will suggest then, after we have discussed this, if you want to write down them again, and then we can go through it, and if there's anything needs to be changed, we will do it. And then in next, few times as well, when you do that, whoever is around you from your, ST4, ST3 or ST5s, just ask them to just go through it, just to quickly have a look to see if it's okay or if there anything needs to be changed. So, once you will do 4, 5, you will be fine to know exactly what to do. And then you ask her about the first case herself to say, okay, so what that is, because we want to engage her as well. So say, okay, so you want to tell me then the first one which you made, what you feel about this now. So she tells you then whatever it is, 29 years old, unilateral, 10 centimeter, this is I wrote. And they have asked me they should have been more routine, and you can say, so what happens basically, I hope you understand by this time, obviously they know MDT. I wouldn't ask my junior, like even FY1 or FY2, about what MDT is. It's something they have been trained as a student as well, so everybody knows MDT. So you can say, so obviously this MDT multidisciplinary team referrals. So tell her about the process first. So say, so what happens basically, this MDT, they meet like once in a week. And there is usually they have one session to discuss the cases, and then they get referrals from all specialties. Obviously, they can be like obviously recent referrals, medicine, surgery, like all of the departments. So in one session or even in 2 sessions, there might be quite a few patients they have to discuss and make their individualized and tailored plans of management. So for that reason, they want really this MDT referral to be quite precise, to have all the important information there. So so they can just quickly have that information, and they don't have to really waste a lot of time to try to find out the information from the patient notes, because then they may not be able to complete their list for the day. And then obviously some patients are already towards the end of their fast track time frame, so it can be breached, and then we see how the consequences. So that's the reason. First, explain why a proper MDT referral is required. And then you will say, so the aim we want to achieve from the MDT referral is also because obviously we do understand what, the consultant who is obviously seeing this patient, they do know what standard treatments are. And that consultant probably has the plan as well in place. But the reason to discuss any MDT is to, have the further opinion to have from that team as well, and then collectively as a team to think about what can be the best appropriate treatment management for this particular patient. Yeah, so that's why it's very important to add some other information about that patient as well, like for any other conditions. And then you can say, so what I do, there is a template of the unit we have to on the MDT referral. So hopefully if they bring that, they should give you some template over there as well, which you can scroll down so you can show. Otherwise, this is how kind of it should look like. Just a standard letterhead of the department to start with. So the name of the hospital and the address on this side of the form, and then the team who this letter is going towards. Yeah, so lead clinician. So MDT, obviously there is a specified named MDT team. So there will be some MDT lead. And then you will have the lead clinician of that particular patient. You need to tell as well lead specialist nurse, and then any gynae coordinator. We usually are kind of medical secretaries, you can say, who will basically arrange, check which one is coming towards the target, which should be priority based discussed today. So they will just arrange that kind of administrative work. So they are there. So there's the detail of the referring person. So it looks like coming from the GP. So that's why they say GP details. So if it's coming from your department, you can put your department details here. So whoever is referring that, yeah, they need to have their detail and the patient details here. So you can see what that require: name of the patient, date of birth, obviously consultant's name, who's underage, because if the team needs to communicate anything and who is responsible concerned, they need to be there as well. And is that patient to waiting criteria? Does this patient and this particular referral come under that? Then that will be written over. And then in that case, then we also need to give the target date, what that is. And I said, like, obviously this waiting, two weeks waiting, obviously is 2 weeks. And if you're meeting once in a week, then maybe that we had the meeting on Wednesday and this patient actually we received on Thursday. So by Wednesday, when the first meeting will be, since this patient has come, her 1 week would have already been gone. So that means this patient must be discussed in that particular meeting. Okay, so that's the reason why there needs to be. And this is exactly, you can explain the way just I'm teaching you, right? You can just explain. So that one is there. And then no, the summary means like we need to give the information, all the important information, like, you know, what condition. So if there's a particular cancer, what cancer they have, this person has. If there is any histopathology, which usually we'll have by this time, obviously she would have a biopsy or something done, for which reason we have diagnosed this condition. That needs to be given over there as well. We need to also add the any important test finding, any relevant, right? So no, when I say relevant, that doesn't mean the routine full background USG and LFTs and everything needs to go there, unless this patient has some kidney or renal disease, you know, renal or hepatic disease, then we see, then yes, those results needs to be attached. Otherwise, relevant results mean, say, for example, if it is MTT referral for some ovarian cyst, then we need to give the ultrasound report result, then we need to write down the CA125, and then what we have calculated the malignancy index for that woman, and histology report. On the top here, obviously, again, the diagnosis, histopathology, and any other morbidities this patient has, like any diabetic, hypertensive, or whatever. We just need to mention, say diabetic, hypertensive, maybe asthmatic, all under control in medication, on medication. That's all you need to tell as well, because this MTT basically is going to decide, okay, if we feel, yes, the best treatment for this patient is for to go for the surgery, but what if she has the other medical conditions which make her actually unfit for the anesthesia, and we can't go for the anesthesia? Then obviously they need to consider that and then think, okay, if we can't go, or can we actually have some alternative options for the anesthesia? Or if not, then can we then, you know, I mean, depending upon the, then again, the complications of the problem. So should, okay, in that case, we can't go for surgery. So should we go for radiotherapy? Yes, that's why you need to explain as well why that information is important there. Yeah, and that's all you will do. And if that is something, again, you know, inherited in the family associated, that again, family history doesn't mean anything, like, you know, you can write, you know, maybe VTE, or any other, if that particular condition is in the family as well, because if she requires a surgery which may need to go up to 6-7 hours, and her BMI is 40, and there is a history, herself, a family history of VTE, then that needs to be in plan as well. How are we going to actually provide that VTE prophylaxis during the surgery, intraoperative and postoperative as well? Yeah. So they obviously require anything which will require extra preparation for that. That needs to be the part of there. And then, so if you look at there, so it says all, yeah. So few here, then comorbidities, and then points for discussion. What we want clearly to ask them. So radiology findings are there, MDT plan action that we write it down here later on. So then you need to ask the question, particular question to be answered, and what we want. So you will say, like, is surgery suitable? Or maybe the patients have said something particularly. I don't want particularly, you know, when we tell, okay, these are, she might say, well, no, I just want some, you know, control of the symptoms. I don't want basically to go for the definitive treatment and then end up having so much morbidity and complications that my quality of life goes so down. Yeah. So maybe then we say, okay, give her chemotherapy, or give her some courses of radiotherapy to shrink tumor and then leave, and then we exaggerate, maybe do that. So the patient wishes, if there is any particular, she says, priority as preference, that should be included as well. Okay. I used to have one more perform. No, that's different thing. Yeah. All right. So very simple and straightforward. And that needs to be literally kind of in one line. The bullet points, comorbidities, they all need to go in one line, like diabetic, hypertensive, cardiac disease, whatever, all under well control under their medication.
Madam, what is this performance status 0, 1, 2, 3, 4?
Performance status is like, again, that will be something, I mean, it shouldn't be really here, it should be down here somewhere. So the final staging will be agreed and done in the MTT meeting. and the performance status as well. No, I don't particularly know what this particular trust mean by that, and I mean within the team they must know. But sometimes the overall performance status is like keeping the fitness of the patient, like suitability and all that. They grade them. What like very active and everything is okay. Like there's no contraindication or no complications or problems to go for any type of condition, treatment options. So maybe like that, but I don't exactly know, to be honest, what exactly they mean. So if the performance status won't be something you need to worry about, even by making the referral. I wouldn't actually put performance status in the pro forma.
Can I explain here about the performance status?
Yes,
Dr.
that would be
Juby?
good. That would be good if you can, Sadia.
Because
Yes.
because we fill in the MDT performer and performance status, usually there is a key given to the performance status. Performance status 0 means I don't know in what status in this particular scenario whether 0 is the best and 4 is the worst, or whether 0 is the worst or 4 is the best. But we usually have a key which tells us. So number 1, it is patient is perfectly fit and well.
Yeah.
She is able to perform all her activities independently.
Yeah.
Number 2 is patient is usually fit and well with some limitation of physical activity. Number 3 is patient depends on others for her routine activity, but usually is mobile. 4th is that she spends most of the time on bed, and the 5th is that she's bedbound. 4th is that she's bedbound.
Yeah.
So because making the MDT decision, they need to know whether they are over treating someone who already has multiple comorbidities and who is bedbound. Would it be wise decision to put further stress on such women?
Yeah, that's right. So in simple words, I said already that that's about the fitness level, or we are saying the performance state, like how fit that patient is to accept the different options, right? And this order can be different, again, depend on that particular unit. And usually at the end, at the bottom of the performer, it will be written there. The 0 means this and this, so you can classify in that. But that is basically according to the fitness, like whether is that patient basically, is there any restriction, or this patient actually can't have any of the management options, right? So you will obviously include everything on their comorbidities and the status of their disease and everything. And if there is say for example, just I said like this woman, as we said, like somebody, if they have like some cardiac disease or something, any condition which can restrict maybe their anesthetic options or something like that, so then we will be taking from some of these as well. So that is like how freely and how fit or good they are to have the option wise. Are there any restrictions? No restrictions at all, some restrictions, dependency and all those stuff that will come here. All right. Right, so next.
Is there anyone remaining in the I don't know who has done. Lubna did.
Okay, just give me 1 second.
Those...
Just tell the person who is next so they are prepared for that.
No, I think we have reached the end of the list.
Okay.
Sadia has done, isn't it?
Yeah, Sadia has done.
Yeah.
Okay. So now regarding like how we do it, so I just made a little note here as well, like what you could include, right? So this was the first one to decide. I mean, this is the type of which you want to have. Put into the notes, from your notes. This will be the type of information you can put, okay? So name of the patient and 52 years. And if you don't repeat that here, present with schemas, this you may not need to, because you have written the name of the patient and age, everything up here anyway. So you don't need to even write on the name and stuff. Just say squamous cell carcinoma, extended to lower third of 1/3 of urethra, right? And then you have histopathology, just here just add whatever that is quickly in single line, or even one more line down if they require. So this needs to be there. And then the next one will be kind of investigations. I mean, I have just written some normal just to help you, so if there is, because there is not particularly written as such investigation, but obviously investigations needs to be there, but again the relevant ones. If there was like the routine, unless the hemoglobin for chronic, if she has some condition which causes her anemia and stuff, then again you need to think that investigation need to be there, which can affect the management option for her. All right, so say again, if we stick to ovarian cyst, CA1 to 5, what is the level of that one? And then radiology, x-rays, whatever we have done, like ultrasound scan and CT scan information, you will just add like that. Comorbidity, as we said, diabetic hypertension or whatever, and they are under control, under medication. And patient wishes, what she wants to do, if there are any, because we do ask, we discuss, remember when we discuss with them these options and we say this is there, and then we say, we do that, but it's, what would you like us to do? Or is there anything particularly? And some patients will say, okay, no, I don't want to this and I don't want this. So if there is something particular, patient preference, that needs to go there as well, because for us, we might think she's fit. She can have actually any option, surgery and after the radiotherapy or chemotherapy or whatever. A patient might be thinking something different to say, no, I don't want to end up in all that stuff. So this is what the amenity referral look like.
And family history is also a part of MDT referral.
Yeah. So family history. So family history will be there for we said about any previous condition.
Yeah, thank you.
I will expect if they put that, if they give you that station, there will be pro forma, because you can't teach otherwise. Yeah. So there will be pro forma given there anyway. So you need to be, more than what the pro forma look like. You need to know about like what is important and why. That's what basically we need to explain that trainee to understand. Just basic things really again. Okay, so what else? Okay, we can go through the maternity dashboard. Right. So we are going to go through the maternity dashboard, and then I think it was Sadia who gave us that 39, the increased rate of cesarean sections. How will you bring it down?
Yes.
So first of all, so if the scenario is, how we know basically that we are going above the, our rate is high, and like how, from where we get that information that we need to do something about it. So that's the maternity dashboard. All right. So maternity dashboard again is a standard national system in place. So it's same. It will look same in every trust, in every unit. Okay. And what is the purpose of maternity dashboard? Just to look first. So this is how the maternity dashboard look like. You will see here are the numbers of the names of the months, and then you can see 3 different colors going on in here: green, amber, and the red. So from the guidelines, sometimes from NICE guidelines, your college guidelines, then there is some national standard. It's given by the Department of Health to the trust and to the units for certain things. Okay, so they kind of is more to do with the quality of the service provision, and also about the safety. You can say it's come under the quality control domain of GMC. So like they want to make sure that we are doing the right things. The trust can identify earlier if they are not reaching to the national accepted level. Then it's not something, these numbers, the Department of Health or whoever, they agree and they just send any random number and they want us to just maintain them. And doesn't matter how we do it. No, that also come from different studies, observations, and like what is overall. They have also done first some collection of data on that to say what an average, say for example, if we just take from the cesarean section rate, what in a, most of the units, what is the practice, what is happening, if they're doing like normal, average, good standard practice, what is, in what range they actually have the cesarean section rate in their unit. Okay, so from that, then they collect a lot of that data, they observe, do the analysis, and then they set up these ranges for us, and then they send to the units to say they should meet these. If they go beyond it, they should get early warning that they need to do something about it, or red means immediate action needed to see, look to find out why we are not able to actually do according to whatever most of the other units can maintain, and then try to find out the reason, the causes, and then try to do something to prevent it. And then in maternity dashboard, then there are different domains you will see. what we need to monitor. Okay, so the first of all, maternity dashboard obviously is, again, as I said, is a set of local goals for each parameters to be monitored. And then they give us a range. They don't just say to us completely, say, you must maintain your C-section rate at 25%. They will give a range like 23 to 25%, something like that, right? So there will be range. So they will give us some upper limit and lower thresholds as well. And then, the traffic light rule came up, so the green, and that is again electronic system. Okay, as soon as I will enter the numbers when I'm entering the data, these colors will change themselves. All right, maybe I'm tired and I'm all that stuff going on, and I'm just sitting late night or sometime and just I'm entering number. I may not be actually active enough. Again, there's this safety backup. I may not be safe enough to, at that stage, alert enough to find out whether we are within that rate or not. So this is, again, a pre-computerized electronic monitored system, where as soon you will enter the number, if that is within the goal range, it will turn automatically green. And if it comes into our, the range like 23 to 25%, then it will go amber. And if it goes like more than 25%, will turn up red. And that will open up my eyes then. All right. And then I will do something about it. Okay, so that's why this light system came into place. Now, who monitor it, and what we need to monitor? First of all, what type of, is that only the clinical activities we are interested in? We want some unit to maintain certain number of forceps deliveries, don't go above this and don't go below that either. It's interesting, very like if some unit has the number below the certain, maybe, instrumental deliveries, that will also be a point of concern. Why? What are we doing then? The woman needed instrumental delivery, maybe we kept delaying to deliver that baby. Okay, so say, for example, we will say exactly what rates are. Say, for example, it should be up to 15% or 10 to 15%. And that unit always have like 5% instrumental delivery. You find it very proud of, we have then. But I will be a bit concerned. I will say, okay, give me the reports of all the neonatal babies, what Apgar score they were born. Like, what is your unit's rate of complications of the newborn baby? Because we also, if it is that, that's fine, well enough. But we need to make sure, is that like we're just sitting okay because we don't want to do the instrumental delivery, but then we are delivering quite sick babies because we have been waiting too long. So it's not penalizing practice or exercise. It's just like to stay within the safety, and just a reminder to stay within the quality limits. So the things which we can monitor and are part of the maternity dashboard, again, they are pre-arranged, set up, national level, clinical activity, then workforce. So if you want me to maintain that certain standards, you need to give me appropriate workforce as well, appropriate staff as well. All these complications and these things will happen maybe just because I don't have enough staff. If there should be 10 midwives for the night, we have only 5 midwives. Of course, in this unit, the number of abnormal CTGs or, these are complications is going to be high enough, because those midwives can't divide themselves into 2 each to do the job of 10 midwives. Okay, so that will also be monitored, so that can also be picked up. And if you need more recruitment, do that recruitment. If you can't find the staff immediately, and if you even have to reduce the number of patients, then close your unit earlier. All right, or maybe close even complete if you think you don't have safe stopping levels to continue. Clinical outcomes, again, clinical activity and outcomes is again like about the bus. We'll go in a minute here. And risk incident complaints and patient satisfaction surveys, they are also the part of it. Okay, so not only again that we just will put the complaints and risk to see only penalized point of view. The patient satisfaction surveys needs to be there as well. Now, why and what is that basically? So that doesn't mean that they should always be full of praises. We are supposed to actually get the feedback from service users as well, and we must do that, because we might, we can hide our data, we can maybe play with the numbers, we can do anything, and this happens. It's not unusual. We know in here there have been some units where quite, those actions were taken, they were even closed because they were playing with their data and for their numbers and stuff, right? The patient satisfaction service is like, again, by national standards, we are yes, so it is compulsory for us to attain a certain number of patient satisfaction surveys every month. So the patients, when they attend for outpatient or when they are inpatient and they discharged, now these days, obviously, old days, there was a paper feedback paper they were given to complete and put into a box. And these days it's an electronic one. So when they get discharged, the admin staff will automatically send them a link for that survey, and that will be completed and come back to the quality control team, and they will then add up to that one. So we must get a certain number of survey feedback from the patients per month as well. And who does it, and like whose responsibility to look after? So usually, again, these things, quality control and safety, they usually all come under clinical governance, and the clinical governance, usually there is a lead, not usually, it's must. Again, every department must have their clinical governance lead. They usually are, if we talk about ops and gynae only, there will be one labor ward consultant most of the time, because the lot of elements of this are obviously maternity dashboard. They are about the obstetrics. So there will be the lead labor ward consultant, and then one of the midwives as well will be the part of the team. Okay, so that can be one senior midwife or somebody like, and then with them usually is some trainees or junior trainees as well, like some ST5, ST3, who, they can be one of that and one of the midwife as well. Then above the level of the unit, you do have, the trust team of clinical governance, or risk management team, right? So all this information, initially we are looking and putting into, then that all will get submitted to the trust central of these. So from all these units and specialties, that data is coming to that central, that team as well, who is a trust clinical governance team. All right, so we need to have one member from then as well as the name for that particular service. Okay, so they are usually called risk manager or clinical governance managers, or every trust may have a different name for them. And then just like there will be some from midwives as well. So they're called lead midwife for risk management. And then you have, a member from team as well from the trainees. And information should also be regularly passed to the directive management team. So that's the central trust team we are talking about. So what we need to enter and how does we interpret this? I can't enlarge it more than that. So if somebody needs to put the reading glasses on, please do so. Let's look at this part first. So we said like we need to look at the clinical activity. Then we said the other element we monitor is workforce. Clinical indicators or the clinical outcome we said. So let's see if I can get it down a bit. No, I think that's all I have for the picture. But anyway, down here is the fourth one is about the patient service satisfactions or complaints and incidence forms. Then, so this defines which particular parameter are we going to monitor. So say, for example, organization point of view, or the teams, like any whole team even, not particularly the clinical team, but the management team of that particular unit as well, and the of that unit, they must have the appropriate representatives from all the diverse groups. All right, so it can be like all different ethnic groups or whatever. So if we say, okay, so we have a labor ward forum, which I said there will be a consultant labor ward, we say call consultant and the midwife and whatever. They need to have, say, if we say, okay, labor ward forum, there are going to be 5 members, depending upon obviously how big the unit is. Then we need to think about, out of those 5 members, there should be at least 2 representing different ethnic group, or maybe 1 minority group as well, BAME group, yeah. And then different type of those, we can't just make, okay, let's put all the medical staff here in that forum, all the doctors. No, they need to be then again the type of representation here. We need to have some part of this, like some nurse or somebody from the EPAU, some midwife, consultant. So again, you have all from your different multidisciplinary team representation as well. All right, so they can all make what is better, again, to keep it a standard without any bias and anything. And so that, and these measures are required to prevent, sometimes a group of practitioners, a group of people, they all together actually they all become on the same ground. Let's keep our lives easier. Yeah, start clinics late, finish early, Who is going to monitor you and ask you? Okay, so to prevent these type of things, they need to have all type of representatives. And then these are the goals given to like what you should be. So they say, okay, they should need to be 4 different representations. The minimum is 2. Say, for example, if they say, okay, you need to have that like 4 different, the diversity I have talked about, there should be at least 4 of them, but the minimum acceptable is 2, because sometimes there can be recruitment issue. We may not have, there may be a team where they all are, the white consultants and the midwives and everybody. Maybe that's the part of the country, but it's very unlikely that there won't be anybody else, right? So the minimum acceptable will be 2. So 4, 5, okay, 3, 4. So this is and the between is the range. Okay, so if you don't have the 4 according to the number of staff we have, when we are, this number is flickering as between 2 to 4, like 3, which will be, when I put 3, that will come up as amber. And that will give me warning for 1 number, 2 number. I can put something in place to say, well, we have done this, or we've advertised the post, or we have sent further invites to these groups representative to join us, but they haven't. But if it goes for like we have less than 2, there is only 1, or we haven't got anybody, then we need to take action. Yeah, maybe we need to then particularly do some recruitment from that particular, we need to advertise a dedicated post for that particular group, something like that. So you must do that. Right then, and then clinical activity point of view. So then the births, say scheduled booking, how many should be like, scheduled, and those bookings, instrumental vaginal delivery, cesarean section, what that should be. So this is what they have given. So say, for example, we first visit scheduled, and then more than 500 if our bookings are unscheduled, which would be, let's go for something more simple, which is more understandable, come out of the administrative stuff. Mentors and forceps, yeah, or let's go to the cesarean section, the case we're going to discuss about. So the national, according to what the data they collected, they said the most of the units we have seen with the safe practice, they can actually quite easily, most of them are actually, their cesarean section rate is, 23, less than 23. Most of them are less than 23. And then some is range at 23 to 25, but there were only few, or very rare, who had more than 25%. And those one, when they reviewed further data, why that was, they found some reasons why there was, which needed to be corrected. Okay, so this is how these standards come out initially, these range. So 23 is the ideal. If as long as it remains 23, this number 11, 20, 21 or whatever, it will automatically turn green. As soon as I go above the 23, I add those numbers, but below 25, so I have the range of 23 to 24. That will all come as amber. That is just alarm me. It's still not, it's not that it's not is unacceptable, but that is something I need to look into then, that we are going slightly higher than, we can't easily maintain what is going on. Maybe on one number, 23.3, just above, I may not be much concerned here. Second time again we have this, then I might just, then try to just review all those notes of the cesarean section to see what, and then maybe, it's fine now going on. 25, even single reading which goes above this level, when I put it goes red, I have to, in my very next session, I have to actually pull out all that data of those notes and whatever to review for that month. What was the indication, what happened, how whether there was a consultant involved, all those factors, we talk about, and then I must identify what was not being done right or was lacking, that we gone beyond it, and then I have to immediately put some measure in place as well. Sometimes it may be calling for an audit. Yeah, when I said like I will bring all those notes out of that month and review them, what is that? That is audit. Yeah, I'm just going to compare what we did against the national standard, so that is audit. And that's what your scenario was. So they said like in your unit, I don't know what the number was, but that was certainly about 25, 29% or 30%, whatever. So how you going to do whatever about it? That's how it was, Sadia?
It was about cesarean section rate of 39%, so which was alarmingly high.
All right.
And then it was a viva discussion that what should be done and what do you think are the causes, how can we prevent it, and who should be involved, and what can be the causes, and how do you feel about cesarean section for maternal request?
Yeah. For maternal?
Maternal request.
All right, okay. Yeah, so, right, okay, so this is how you identified basically that 39 number was picked up. All right, so what I need to do now then, the immediate thing which I can do is to run an audit. All right, so audit, and then from there, the discussion, you know, when they say what can be done about it and how we can bring it down, that will take you all the way to the full audit cycle. Because that's the only way we can analyze the notes and find out what we have been doing. Are we doing it according to the recommended options or not? And then, you know, all those steps of the audit. If we're not doing, then we give the recommendations, why we have not been and how we can improve it. So that was absolutely an audit cycle then you need to go through. Okay. So should we do complete it then?
Ma'am, what is the source of information? DATEX and something was mentioned in dashboard.
Source of information.
What is it, ma'am?
Okay, let me just go back then. What do you mean by source of information?
Some DATEX something was mentioned, ma'am. What is that column? I couldn't understand.
Risk management, they say. DATEX is, you know,
okay. HOM also something this is. What is it, ma'am?
Okay, let me tell you. So this is like DATEX means, you know, when you say all the time, we will complete the risk incidence form. That risk incidence form or the process is called DATEX reporting. Okay. Hello?
HOM. What is HOM, ma'am?
Yeah, I'm coming to that now. Let me say head of maternity. No, I'm not. I'm just kidding. Let me see what that is. Right, okay. That's what, yes, that is actually head of maternity. That is actually head of maternity.
Really?
So, and the reason for that is because you look what is going on, right? Midwife and birth ratio. So what we're saying is that there should be 1.3. Like one midwife should be saying 1.3 patients, okay? 1.30 patient.
Okay.
Right?
Okay, like
and yeah, and we see that we calculate that according to formula. Like that means there will be one patient in between which is comparatively low risk, which can be looked up by 3 different midwives in between. You know, she's not high risk, requiring more. But if it goes, that ratio goes above 1.40, that means you have less number of midwives available and you are short of staff, and that can be dangerous. All right, that's unacceptable. So that one, yes, head of maternity, which usually is the midwife. They have a midwife lead as well in there, just like as we have lead clinician, they will have head of maternity, one of the midwives. Midwife to birth ratio, yeah, that's what we're talking about. There's supervisor to midwife ratio. All right, so then they have a supervisors as well, just like as we have the clinical ones for their training, for their supervision, and also to make sure they are completing their marks or whatever. So they should be 1.5. And when we say head of maternity means this is the person or this is the source who will pick up this. You know, somebody needs to even say, for example, I am the one to put that in. Somebody needs to give me these. I have my own clinics and all other stuff done as well. Somebody needs to give me this information, right? So that these are the sources from where it will come. So the head of maternity or whoever, that person then has her own system to look after and keep that data and then pass it to me so I can put and keep an eye on this and see what I need to do. Yeah, so that's that team basically, which is again working together. ED and training progress and all that stuff. That's again. So DATEX, I've explained you what that means. Lay pursuit of delivery. Well, DATEX is risk incidence form basically.
And ma'am, do we use, so it is like the end of month statistics that we are entering into this at
That's
each
right.
month, and do we enter it?
Yeah, January, February, March, April, you have that for all 12 months.
Okay.
Yeah.
And regarding this, we were saying about the high risk of cesarean, high rate of cesarean section. So actually here we are using something called as Robson's classification to find out in which category the cesareans are more. Do you have anything like that? Are you, I don't know whether you are using that Robson's system in to find out in which category the patients are more going in for cesarean section, whether it is our induction policy like that.
Okay, so that will come out, that will come from our audit, right? First, we need to identify what, these 25%, what was the reason, what happened, and then we will see, okay, which group and who needs to take action about it. All right, so that we will then, I will continue. So the case we will actually do as a audit, because otherwise it will be quite long now. So that our audit will answer all these questions which Sandy has told us, how we can bring it out, what went and how you feel about it and all this stuff. So in next session, we will cover this all.
Okay.
Okay. Any other something comparatively short which I can do? That's about
Dr. Jabi, is there any case scenario for a retained swab in any of the scenarios that we will practice?
Retained swab? Like risk management, which aspect? Management of retained swab or from clinical risk management point of view?
It was just an angry patient of with retained swab, coming postnatal and having the foul-smelling discharge, which was not picked up earlier, and so this sort of scenario, I think it would be mostly governance rather than in the delivery.
It is dealing with an angry patient. Okay.
Yeah.
And that comes under, yes, it is clinical clinical governance, and it comes under the it comes under the domain of clinical risk management.
Yes.
Okay. So right. Thank you very much. I didn't have, well, I usually put in, but we can put the retained into our clinical risk management scenario. So we can actually do this station now then, and then we close. Right, okay. So will you give us some, shall we do it with you then, because you will have some information what that patient was doing. And Sadia, these two questions, can you post on the WhatsApp group so we can put into proper scenario form? Later on, wherever you have written, just take the screenshot of that and just send it, okay?
I did not have this retained swab scenario. It was, it was a hearsay by someone else. But the 39% scenario, it came into my Bible in May time.
Okay, and what was that?
So it was regarding that you come to know that your department has the cesarean section rate of 39%.
Okay,
what do you
that
feel
one.
about it? Yeah.
Okay, that's fine. I
So
thought
the
this
retained swab was not with my scenarios.
All right. Okay. That was with somebody else. Right. Okay. Yeah, we can do. Okay, so the retained scenario, obviously that depends. If it comes as a simulated patient or it comes as a structured discussion, I guess it will come as a simulated patient. So what we can do about it then? Okay, so obviously this patient will come. She will be angry, of course, and I hope they will give some. Just 1 second, I need to shut the door. Yeah, so to make our life, more miserable, there will be some complications because of that as well. So cesarean section, retained swab, then she developed the foul smell discharge and all that, and then we kept missing everything, we might have done swabs. She wasn't improving. There will be some other lack given as well, then she would have gone really to the bad situation where she would have become almost septic, and then the scans and the MRI or something would have pick up that swab in there. And then whatever the appropriate management is being done, and then now this patient is on our head to ready to sue us, inshallah. So we will apply same template as we do for the angry relative. Yeah. So in these months, when you feel there is like from the scenario, basically you get an idea. When it is about dealing with the complaint or seeing a patient who is there actually to make a complaint that the patient is angry, a couple of things. How to start. When you go in, tell your name. Don't appear nervous or like that. Just confident and calm. Yeah.
And usually this scenario comes in a form that the patient has delivered and she goes home and she's here back to us in the OPD complaining that while she was taking bath, the swab came out through her vagina. Now she has in a shopper bag and she's complaining you and she say that she is going to sue the trust, things like that.
I see, right?
This is a Lisa Joel scenario, ma'am. This is given in the Lisa Joel and has been practiced.
Okay,
Different.
that's fine. That's much easier if that is. But let's put that way as well, if it even come as a boardsman, because the process will remain same. It depends. She might be a drama queen, and even with this one, she might go really mad and shout at us. So what is the standard procedure, how we actually go? And so, yeah, so it's like, don't feel, it's something, yes, it is wrong if it has been, but this is one of the known clinical errors which can happen. Okay, it doesn't come under negligence. So that's the first reassurance. You don't need to feel guilty and appear very defensive, but you need to be open and honest enough to accept that yes, this has happened. Yeah, this should not happen, and then we will say whatever. I will explain in a minute. So go in, explain, take name and date of birth, just sit down, and just with this small opening, just open to say, so I understand you're here. Don't summarize the complaint already, that I understand your swab was left there and blah, blah. No, just say, I understand you're here because you have some concerns and you want to discuss those with us. Yeah. Or if the scenario started to say your midwife have asked you to come and see this woman because she, then you say, so my name is this so, and I'm asked by the midwife to come and speak to you because you have some concerns you want to discuss with us. And then just sit down and ask like, okay, so would you please tell me what are your concerns? Let her talk. She will be angry. She will be shouting at you. She will be do everything which she can't do. So in all that time, you need to sit like, leaning a little bit forward and giving full attention, listen, note, acknowledge as well, okay? And maybe in between, you might need to get some information as well. So say, for example, she starts and she says, I had this, let's start from a small scenario. So I had, and I was taking bath and this small swab came out and it was horrible to see. It was disgusting to see what that is. And I was really worthless to see what the hell it is. And then, I found that it is and I brought it in and I was having so bad discharge because of this. And to add further to joy, I was like really worried why I'm smell. I was taking 4 showers a day and I wasn't able to have the sexual activity because we're embarrassing about blah, blah, blah. So listen, all right? So when she's done, then ask her, no, I'm not going to apologize straight away or something like that. I need to have a little information before. And ask her to keep neutral, to keep her engaged, to bring her, that one. So what I'm going to do is acknowledge first to say, yes, I can say this must have been quite, frightening to say something coming out and not knowing what that is. And then, yes, if swab is there for that long, so, there might have been some infection or something we will also need to look into. And I absolutely understand, yes, if she says, we're disgusting, I wasn't able to, and I'm really sorry that you have to, you have to go through this unpleasant experience. So that's what it is. Then I'm going to ask her a little question here now by saying, okay, so tell me about your delivery then to help me understand the things a little bit more better. So tell me about your delivery then. Did you have the episiotomy or tear down there which was staged? Were you bleeding quite heavily and they need to, take you to theater to examine or something like, because now we need to think about what can be the reason after immediate delivery. Yeah, maybe she was bleeding from episiotomy. And whoever was switching the episiotomy, they might have just put, some pressure on their, hemostasis, whatever, and they forgot then that is there. So just like kind of ask those couple of questions and get all information. So the reason behind doing is I acknowledged. So if I will say, start explaining as well, like this can happen, one of these, but then she's going to be more angry because she has come that she's going to blame us and we have done something wrong, and she knows we are going to give a lot of explanations for it. But as soon as I actually acknowledge and say yes, must have been wrong and all that stuff, she will be okay. That will break her that tempo which she was sitting in. And then I just ask a few more questions from her, right? But they need to be sensible questions like these, right? Okay, so just to help me to understand what might have gone wrong, please tell me, did you have any cut down there or any stitches done, or were you bleeding? No, her brain has started distracting now. Okay, so the anger elements start coming down because she needs to know, give me that information that this happened and this happened. Okay, so and then you say, right, okay, so you when you delivered, obviously, and are you having any pain? Because you see if there is any swab left in there for a day, sometimes we see there can be risk of infection there, and that infection can ascend up as well. So please tell me first, do you have any pain down there as well? Any fever you have? And that also is important to establish the immediate well-being. It's not be trying to only distract her. So ask about those important symptoms first. Any pain, any abnormal bleeding, fever, unwell, all that stuff. And then you say, no, we see she will come back again or whatever. No, you explain what happens. So you will say that you're absolutely right. She would have definitely said this should not have happened, and I was, appalled from the care I received or whatever. You say, so I absolutely agree with you that it should not happen. That is swab is being left inside. So what happens when, as you said, you had a tear down there, or you had an episiotomy, sometimes there is quite a lot of bleeding from that tear. So when the practitioner, they are trying to stitch that because of the amount of the bleeding, they're not able to, because they, taking the stitches or whatever, and if there is continuous bleeding going on, they're not able to see exactly where they need to take the stitch and control this bleeding. So explain how the process, right? So what we do then, we use some of these, gauze, small gauze pieces to actually press and clean the blood. And sometimes if the woman is bleeding, quite a lot, then sometime, we may need to actually put a couple of swabs together to put a pressure on that side, or just to, press that, and so that we can have, or stop the bleeding so these can absorb and we can have some clear area to take the stitches. And then whenever we open the pack, there is a system in place for us to make sure that we actually count the number of swabs we have used, and also to count afterwards as well to make sure there is no swab left inside. Okay, so you can just even say simply they come, in a pack of small swabs together. So when we are opening them, we write the count, we have opened these much swabs, and then whenever this all is finished and completed, before we discard these swabs, we do count them to make sure that they are all complete. And if they're not, then we explore and look back into this by saying, where did the last swab got done? And if it's like still inside the patient, we take it out, or maybe gone down in the basket or whatever, but we always make sure the count is complete. So the robust system is placed. However, obviously, in your particular circumstances, the system has failed. Yeah. But we need to know what and why that failed. Okay, so what I'm going to do, I'm going to report this as an incident, and we will do the detailed analysis to look into that. Yeah, we'll speak to the clinician as well. If it's not me, but if it's me, then obviously I will have to say, well, I have to look basically again why that happened, why I failed actually to do that count at the end. Or maybe sometime it happens, maybe there might have been some very serious emergency that I was pulled out, and I had to rush, and for that reason I could not actually complete my safety checklist. So I'm extremely sorry, even if behalf of the team member, if that happens, we'll say we're extremely sorry that you have to suffer this pain and all that unpleasant experience in that time. But we are, we do take these type of errors very seriously. Okay, and we will do that, look into detail, and understand what failed and where that happened, and then obviously we will then make sure and put measures in place that it never happens again. So that's the answer. And then don't forget to meet other clinical requirements because of the retained swab. Just don't simply take it's a complaint, and we just keep doing for the complaint.
So
If
the
she's
next
still not
question she
happy,
asked,
yeah.
So she also asked about her fertility. She also gets concerned that is this going to affect her fertility in future?
Okay. Okay, so from her symptoms, Asma, you remember anything? Was she having any abdominal pain and offensive discharge and stuff going on as well?
No, ma'am, nothing. She was
Okay.
nothing.
Okay, so okay. So next, we, as I said, like for the clinical point of view as well, we also need to say that, okay, so what I would like to do, if that's okay with you, I would like to do a speculum examination, to put a speculum inside and have a look to see if there is any false milk discharge or any abnormal discharge. I would like to take some swabs just to make sure there's no infection. And the swab basically here will be high vagina swab, or if there is any abnormal discharge, endocervical swab, basically for culture and sensitivity. Anaerobic infections are quite, likely to happen, and that again depend how long the swab or tampon has been missed in there. So we need to offer and do that, that from her. We need to take her pulse, temperature and blood pressure in this particular patient as well, just to exclude any signs are present, and also the abdominal examination to say I would like to have a feeling of your tummy as well, just to feel for, if there is any tenderness, because sometimes if the swab is there for some long time, obviously, and then there was some bleeding from your delivery as well, and that collected blood inside, obviously, because of the swab, some infection can develop in there. So it's important that I do take swab as well and find out if there is any infection, so we can start you on appropriate antibiotics. And on my examination, if I felt that your womb is particularly tender, which can be a sign of infection, then I will discuss actually to start some antibiotics straight away today with you. Would that be okay with you? Yeah, and make sure you tell her that I will call my nurse to chaperone me for this as well, because she's already angry patient. We don't want to know. Give her any opportunity to come next time to say that doctor then missed all this time and they didn't do that. So that's the one thing to do. No, in this particular scenario, when she says then further, is that going to affect my fertility? So I have no asked these symptoms of any active infection present at this time, right? So if it's not, then I will say, because at the moment you do not have any symptom which suggests that there might have been some infection. Are there any sign that infection might have gone up? So I would not expect it to cause any problems, any ascending infection or any problems for your future fertility. However, if there is an infection and that infection goes up into the womb or into the tubes, then it gets spread into the tummy, then I'm afraid, yes, it can't, that infection, when it will heal it can heal with some scarring and adhesions, which means it can, can cause some obstruction in the tube or some difficulties in the, to conceive next time. And if it affects the tubes, it might, infection can get stuck. No, we don't need to be afraid here. I mean, you might feel a bit sinking heart, obviously, if that happened, where I'm going to end up. But we are not going to hide that information for the fear that when as soon as I will tell this, she's going to shout on me even more. Okay, so this is being honest here and open. So we'll say we will do this scan and all that stuff. So because you don't have the symptoms, it's unlikely it will be. However, if hopefully everything remains straightforward here at this stage, and in future when you try for the baby, and if you don't get pregnant in about you've been trying in about 6-8 months or even up to 1 year, you're not able to get pregnant, then please speak to your GP so they can just send you for your tubes check to make sure they're open. Okay, because that's the main yeah, so that's what I will explain her. I will be very open to do that. But if she's in a lot of pain already, she says she's feverish and all that, say, for example, the worst case scenario coming over here, then obviously we will say that, at this stage, obviously it's important for us to control this infection. And after the infection, yes, there can be a risk of this. If it has involved the tubes on the womb, there can be a risk of scarring and adhesions and then obstruction. However, once we have actually controlled your, this infection and able to do that, then the same advice again here. That once you will be ready for the next pregnancy, and when you start trying for that, after stopping your contraception and stuff, and you're not able to get pregnant within a year time, 6 months to 1 year time, then please contact your GP. We will add, make a part of your notes, and we will also write this information to the GP to consider to do a test for the patency of your tubes. Okay, so that's about it. And then if she's satisfied from what information we give to her and what we have said, then it's fine. If she's still angry and say, I want to make a complaint about it and all that stuff, then you will say, yeah, that's absolutely okay if that's what you want to do. So what I'm going to do then, I give you the information and the contact details of our complaint department, and I will explain you the process as well, how you can proceed about it. And this will not affect your right of treatment or your standard of treatment with us at all. All right?
Thank you, Dr. Jameen. Very well explained.
Good.
One thing to ask, because it's a never event. I mean, I know that we don't have to explain it in detail to the patient, but we can simply tell her that it should ideally it should never have happened.
No.
Or such sort of
So yeah,
thing.
so we said, yeah, in the beginning when we agreed with her, and we said, yes, I absolutely agree with you that it should not have happened.
Yeah.
Right? So I
Okay.
said that.
Yeah.
No, I don't need to give her the details of the legal
Yeah.
that all those things that it should not happen. As long as I have told her that we are going to, I'm going to report this as the incidence, and then we do the analysis to find out we have the robot system in place, and then the lessons will be learned, what went wrong, and then we will take the
Yeah.
measures in place. It shouldn't happen again. That is enough for the patient point of view. If it's structured discussion, then still is like that, and then you can, in the structured discussion, you can speak that is come under the category, because when we do the incidence form complete, then obviously you tick the category as well. So it comes under never event. But the way we are going to proceed won't be different from what we usually our process is. So obviously learning, and then there will be discussion, anonymous discussion and learning. If there are any points we need to take into the team, when we have our risk management team meetings, just as an anonymous discussion that, what we should be doing. And if we introduce any further policy here, because say if I was doing that and then there was a major PPH in the other room and I have to rush. No, this is for us when we're doing the analysis. What my midwife was doing, somebody opened those bags for me. And that actually is the duty of that nurse or the midwife who opened even in the room as well, not only in the theater. Yeah, if she has opened those 5, I know even here in UK in the practice, we don't actually, to be honest, count that correctly sometime after episiotomies and stuff. I remember early days of my training, but we should be. Those should be calculated as well, counted as well. Yeah, then the midwives, when they open you and give to you, they tell you I have opened 1 pack, Dr. Javain, say, when we were doing that, okay, 5. And then we used to count them after that. Sometimes we have to even pick up from the bin to say, yes, there are 5. And I remember shouting and telling the midwife as well, I've counted them, they all are complete 5, and now they're going in the bin. So that's okay. Yeah. So there is obviously a system in place already. We do write the number of swabs being open back, small gauze, large gauze is water, and then the clinicians need to check with the assistant. If there is assistant to check, is all the instruments and swab count normal? And if you're just doing something small, then we do count them. Yeah. So yes. So this is how it is. So we're gonna close here.
Thank you, Dr. Jatvi.
Ma'am, can we do a station on FGM?
We can't do station on FGM? Yes, why not? Okay.
Dr. Safia, sorry, we didn't answer the question about the maternal request cesarean section.
Okay, what was that question, sorry?
The one Selena was mentioning that the examiner asked her, what do you think about the maternal, what is your opinion about maternal request cesarean section when they were discussing the dashboard?
Okay, so we haven't completed the station, sweetheart, yet. Yeah, we said we're going to complete that tomorrow in clinical governance session. So I will complete all those answers, because once we will do that, the first one, we will start it from there. I have told you today just from where we actually pick up these things, that this section rate or this thing is this. I know I'm going to, in the next session, I will tell you now how, all those questions, what can be done about it, how it can be controlled, and how it can be prevented. And then, yes, we'll be discussing that, okay, the cesarean section rate, what can increase the cesarean section rate in some unit, and what we can do. So then we will discuss this maternal requesting as well.
Okay,
Right?
thank you. I thought we discussed it already. Thank you.
No, that will be sorry. That station is not completed yet. We just left it because that will go quite long because I want to cover the whole complete audit process as well, because this is how you are supposed to basically answer that. Okay, that's completely just total absolute audit discussion basically. All right.
What are the things we're going to discuss in the next session? Just to get an overview.
So the next one, we will be obviously doing this, then risk incidents, then we will be discussing the discharge letter. We will be discussing, yeah, so this all is still going audit.
Ma'am,
OSAT
prescription also.
Prescription will be there. We will be doing OSATs, how we complete the OSATs, and then how we resolve the conflicts on the outcome of these OSATs. Like we may feel this person needs to improve, but the person feels, no, I'm competent to sign me off. That will be kind of conflict, how we sort them out. What is the process for that? So, okay, and what else we are doing? I can actually send this recording to you all. I would really like you actually to all listen this, because that will make it easier for you people to understand than we'll be talking. There will be quite a lot to discuss in this on reflection, enhanced recovery, meals, and everything. I will send this recording to all the groups, okay?
Okay, thank you, ma'am.
Thank you, ma'am.
Thank you.
Yeah,
Thank you very much.
Bye.
And Sapna, if you can put that FGM scenario in the group, Madam can include it somewhere.
Great, thank you, Pramila. So if Sadia has left already, so Pramila, please, if you could put in the group and ask Asma. I think Asma is not in July group. Sadia, Selena, whoever these scenarios were, to give us full details of those scenarios. Put as wherever they have, just put the pictures.
Yes,
okay.
I'm still in the group. I will write down about what private questions were asked regarding this
Thank you very
39%
much.
cesarean section, and I will send in the group.
There was one question in this recent exam. I don't know how because the candidate who did was not sure how to do that scenario. The question was like there were two growth charts given of the twin pregnancy, and it was according to the candidate who was coming towards the LGA side or in between that, but she was not sure what, because she said there were no lines given. It was only that the dots were mentioned, so she couldn't make out it, and it was MCDA twins. And she was there at 32 weeks to discuss about the mode of delivery. And
Okay. So, okay, Asma, whatever information you have about this as well, if you can speak to your friend to ask about what questions were being asked and what the discussion was about. And please, if you put that all in the group, and then we can discuss them. Okay, there are only 2 sessions left now, and it's up to you guys now how you want to use them. Okay, so put maximum things in, and you have to give me the information, because I'm not, kind of, I don't know. Yeah, just put the details of the scenarios. All right. Bye now.